The time is 9 o'clock South African time. Allow me to call the room to order. Good morning, distinguished participants. My name is Lindiwe Majele Sibanda. I'm the chair of the local organizing committee. I'd like to recognize the presence of Professor Ernest Ariti, Arua Secretary General. Thank you, sir. I'd like to recognize the presence of my Vice Chancellor, Professor Tawana Kupe of the University of Pretoria. Welcome, sir. I'd like to recognize the chair of Arua, Professor Barnabas Nawangwe, who is with us here. He's Vice Chancellor of Makerere University. Our VIPs are a long list. It's not my duty to announce those. My duty in the local language is a Tumamina. I stand here on behalf of 13 Tumaminas, and that means you send me, I go. This is a committee that has been working tirelessly since May this year to help with the local logistics, to help support the overall steering committee of this conference, and to ensure that this day happens. We are celebrating because it is happening. And thank you to each and every one of you who've made it both online and physically. The list of the Tumaminas is projected up there. You can see we were supported by Professor Sheikh Mboa, Professor Frank Swanepoel, Professor Kukuvoy, Professor Tivani Mashamba Thompson, Professor Lynn Marie, Dr. Mohamed Mullah of the University of Wits, Dr. Flavia, Dr. Farai, Dr. Nogtula, Miss Esley, Mr. Lufingo, Mr. Jonathan, Miss Rehab, Miss Beulah, and Mr. Louis, who is the man of the show, who is running our IT systems. For those who are joining us online, there is a button on your computer where you can press and put your Q&As, and we will try and respond with answers. You can put your comments, your questions online, and there will be a team that's responding to those. For those in the room, our conveniences are just outside as you come out to your left. But because we are living in a COVID era, I have asked Ms. Beulah Chabalala to come up and just give us a 1-minute pitch on how safe we are. On behalf of the local organizing committee, we just want to say thank you, and we want to say feel free to Tumatina. We are there to serve you throughout the 3 days of this conference. Thank you very much.
Good morning. My name is Biennial Chabalala, and I'm one of the senior events coordinators at Future Africa Campus. My purpose is to provide you with information to ensure your safety and comfortability during your stay. There is an information pack regarding important contact details that you should have received along with your conference bags. Restrooms are allocated behind the auditorium, which is this main room, just down the ramp on your left-hand side. Refreshments will be served in the dining hall, the glass room across this room, and kindly keep your mask on at all times, and please make use of the various sanitizing points. If there's any information that you require, please feel free to speak to any of our reception staff members at the reception desk. Welcome and enjoy. Thank you.
We now hand over to you, Professor Arete. Thank you.
Good morning, ladies and gentlemen. Our chairman for the occasion and also chairman of the ARUA board, Professor Barnabas Nawangwe, Vice Chancellor, University of Makerere, our host, Vice Chancellor, Professor Tawana Kupe, the Honorable Minister of Health of South Africa, who will be represented by the Deputy Minister, our distinguished keynote speakers, ladies and gentlemen. Let me begin by thanking all of you for either making it to Pretoria or making it to Future Africa Campus for this morning's event. It's been almost 2 years in planning. I'm very pleased that finally it's been possible for us to host it here. And I'd like to thank the Vice Chancellors of University of Pretoria and University of the Witwatersrand for agreeing to host this event for us. And they were also agreeing to support us financially for this event. Thank you very, very much. The theme that we've chosen reflects what we consider to be one of the biggest challenges of our time. And indeed, for this current period, the pandemic provides an obvious target in terms of what we need to do. So in having this conference on this particular theme, it's our way as ARUA of assuring the region of our commitment to finding solutions to African problems. That is what indeed ARUA is about. is set up to find solutions to the region's problems, and that's why we're focusing especially on the Sustainable Development Goals, the SDGs. At the end of this conference, we hope to be able to tell not only the African governments, but also the wider world, what African researchers and their associates from other parts of the world can do in order to address the challenges of our time, namely the pandemic. ARUA is 6 years old, and this is our third conference. In hosting these conferences, we seek to create a platform where our researchers from all parts of the region can engage with their peers and also with others from other parts of the world, particularly the global north. So these conferences seek to bring an opportunity for young Africans especially to share their research findings with others and provide an opportunity for them to engage on the global scene. We look forward to many years of working with you, especially those of you who are working with us for the first time. We have in our midst some of the early career researchers from various universities of ARUA who will be working with the Centers of Excellence on the final day of the conference. We look forward to these young people becoming the big researchers in the next few years. And it's our intention to nurture them, support them, and groom them to be the next generation of leading African researchers. I end by thanking you for coming, and I look forward to our collaboration with you for many years to come. Thank you very much.
Thank you very much, Prof. Areti. I don't know if there's going to be sanitizer for... I know Prof. Coupe is fussy about that. Thank you. Otherwise, he won't come and speak. Okay. I'd like now to invite Professor Tawana Coupe, the Vice-Chancellor of the University of Pretoria, to give the official welcome remarks. Over to you, Prof. Coupe.
Thank you, Professor Spanda. You might think I'm fussy, but those are the health regulations. The minister once pointed out when I started speaking that I hadn't sanitized. So we must adhere to that in these times. But thank you very much. So I would like to acknowledge the following guests. The Honorable Minister of Health, Dr. Matume Joseph Pasha, but I understand you'll be represented by the Deputy Minister. Professor Barnabas Nawange, Vice-Chancellor and my peer from Makerere University and the Board Chair of ARUA. Professor Ernest Arite, a very stellar gentleman running our organization, who is our Secretary General, and Professor Lindiwe Majele, Chair of the Local Organizing Committee. I've been asked also to acknowledge the first of our keynote speakers, Professor Salim Abdul Karim, Director of CAPRISA. You will see on that board we have a whole list of our keynote speakers. I'm acknowledging Prof. Karim because he'll be the first keynote speaker, but I'm acknowledging all of them. A very good morning and welcome to the Future Africa Institute and campus, and also for those who are in other time zones. These days, because of the virtual world, people join in from all over the world. I've often given speeches here and elsewhere on campus, then got a note from someone in China, in Australia, and in the US, because these notices float around on the internet, and people register, and they're free to register. So good afternoon and good evening. Colleagues, partners, and friends, it gives me great pleasure to welcome you to the University of Pretoria, and more specifically to the Future Africa Institute and campus, one of our 4 new showcase platforms for transdisciplinary research launched since 2019. I think in the context of Arua, it is important to emphasize this point. This institute and this campus is not just for the University of Pretoria. It is what we call a collaborative transdisciplinary research platform. In other words, it is a platform on which we work together with fellow Africans and also with global partners. If you like, that's why we call it a platform, because it's not an institute in the narrow sense of the word where it looks at the research specific to it. It is a platform where researchers and collaborators from the rest of the continent and the rest of the world meet. It is also a place to support emerging early career researchers. One of the programs we host here, for example, allows for young early career researchers to live here for 2 years, because the other block you saw with multicolors is actually an accommodation block with various types of accommodation. And that will contribute to a pipeline of early career researchers, which is one of the pillars, as Prof. Arite said, of what Arua seeks to do. I'm excited today because Arua has seen it fit for 2 South African universities, the University of the Witwatersrand, WITS, I suspect I used to work there, and the University of Pretoria, to host this biennial conference jointly. May such joint endeavors for impactful transformative research become commonplace among African universities. And that is one of the aims of Arua. The theme of this conference, Global Public Health Challenges Facing Them in Africa, is timely given that we have gone through what we have gone through because of the COVID-19 pandemic and what we are still going through and will still go through before we can, in a sense, have a control of the nature of this pandemic. We are not out of the woods yet. We must remain vigilant and master all of our resilience. We must also use all the tools in our lessons learned folder to ensure that we overcome a global pandemic that has eroded livelihoods, resulted in so much loss, including, of course, loss of life, utter devastation, and impacted many economies, including our own rather weak African economy. In spite of this, I've always said, and I'm happy to repeat, there is a silver lining to the COVID-19 pandemic, just as always there is a silver lining to a dark cloud. We've learned to think and work in ways we never imagined were impactful. This hybrid conference with a mix of in-person, us in this room, and virtual speakers, those who are online, and participants, is a perfect example of lessons we learned and are now adopting as normal. We all know how it was expensive to go to conferences and what hoops you have to jump through, even when those conferences were on the continent. The visa regulations, the cost of airplanes, the cost of accommodation, all of that. And also, when you went to Europe, again, the visa regulations, all of those. Now we can, if you like, leapfrog, transcend those barriers by using some of the online platforms. Let me add, of course, that virtual only is not sufficient. These kinds of conferences and education by nature is social. The human in-person contact is very important. All of you sitting here know that how many ideas, how many research projects were incubated on the sidelines of a conference, at those dinners, at those after hours discussions between colleagues. So thanks to digitalization, that has allowed speedy and effective communication channels. Those who know me, I'm told, branded me as Mr. Transdisciplinarity. In truth, I'm only a student of transdisciplinarity, something that all of us are grappling with. I simply wholeheartedly believe that all silos in the conduct of research and knowledge creation must be broken to open up the opportunities for research to solve the complex, complicated, even wicked, and intersectional problems we face as a continent and our societies. It is for this reason that the pursuit of transdisciplinarity is close to my heart. I believe it is key to helping us address local and global developmental challenges, including the COVID-19 pandemic, and the pandemics that we will face in the future. Remember that this is not a once-off in a lifetime pandemic, because the causes of this pandemic will be the cause of other pandemics to come. Our duty is simply to be much more prepared. and also to be able to address those causes. It is key in helping us achieve the sustainable development goals. By that I mean transdisciplinarity. Transdisciplinarity is the transformative pathway to better futures characterized by harmony between humanity and the planet. Remember that many of the problems we face in the world is that disjuncture between humanity and nature. Or to be a little more precise, is how we have actually, in a sense, abused our planetary resources. And there is a big comeback to our health, to our economies, to our livelihoods, and to all of those things that should create a better world. Therefore, ladies and gentlemen, I'm excited that you are here at Future Africa to discuss how we can address global public health challenges. You could not have chosen a better venue. Future Africa is coordinating the COVID-19 Research and Engagement Platform called COP to harness a vibrant community of practice driven by the University of Pretoria in partnership and collaboration with colleagues in academia across our continent, Africa. The future lies in collaboration and partnerships. There is no go it alone any longer. We know that go it alone has failed to actually enable us to master all of the resources needed to address the challenges we face. The critical principle of COP is the pursuit of transdisciplinary research that brings various teams together to co-design research questions that are focused on local and global challenges and co-create knowledge for greater impact. CO will not be limited to COVID-19, although created in response to the pandemic and its cascading social, ecological, and economic impacts. I've looked at the conference program, and I'm very impressed that for the next 3 days, you will be deliberating on precisely the type of issues that define our humanity in the 21st century going forward. Moreover, as Africans, I'm glad that we are taking proactive steps to understand the changing dynamics of global public health and how they impact us. There is nothing better than taking charge of your own destiny. And there's nothing better than co-creating knowledge as an instrument of, if you like, getting hold of your destiny and creating better futures for yourself. I urge you to take time to unpack the societal impact of global public health challenges in Africa. COVID-19 is the most recent, but the continent has seen many severe pandemics with devastating effects. Cholera, dysentery, malaria, hemorrhagic fevers, for example, Ebola, Rift Valley fever, Crimean Congo fever, and yellow fever, to name just a few. And not, of course, to forget other diseases that still plague our continent and result in life-limiting and destroying situations. Here is the problem we often face, and that we face a specific challenge at a particular time. We run in that direction and almost put all of those resources there and forget that there are multiple intersecting disease challenges that the continent faces. HIV/AIDS is still with us. Maternal child health is not what it should be. And breast cancer, you can go on, and I listed some of the. So we need, if you like, and that's why transdisciplinarity is important, to have a holistic view of the global health challenges and treat them not as isolated phenomena, but as actually intersectional phenomena. I would say, while we know the challenges, to be responsive, we need to drive research agendas that produce knowledge-driven solutions. Knowledge-driven solutions are what we should offer to policymakers to complete the value chain of transformative impact. If we co-create knowledge that is impactful, but it stays in our journals, in our books, and in our conferences, we have done, if you like, half the job, or perhaps even slightly less than half. We have to actually ensure that we have mechanisms to translate that knowledge into the policy domain, evidence policy making. That is by no means easy. And also we need to appeal to the stakeholders, who are policymakers, the politicians precisely, to be appreciative of knowledge, and that to best govern our countries and to achieve things like the Sustainable Development Goals or Agenda 2063, the Africa we want. They need to have the capacity to absorb knowledge-driven solutions from our institutions. And also it's important in this regard that in venturing into the domain of using knowledge-driven solutions to translate them into policy, we do not compromise on scientific facts and we do not compromise on academic freedom and freedom of inquiry just for political acceptability. The conference is timely given the recent COVID-19 vaccine drives, which have in some instances polarized the continent. We need to pursue vaccine development in Africa and contribute to capacity building to make sure that we produce vaccines ourselves without relying on pharmaceutical companies from the global north. While we are at it, we need to reimagine life beyond the reactive measures to the pandemic by learning how to live with the virus. I have colleagues here, I'm looking at the other side, there's Professor Makota, there she's an expert on zoonotic viruses. I think she will, when the opportunity comes in, tell us that, well, there are more viruses coming your way. Your responsibility is knowing how to live with them and preventing the worst possible harm, as we have seen with this pandemic. Given the social and economic consequences caused by the pandemic, and also the responses to the pandemic have often, some responses, let me say, have often exacerbated the impact of the virus itself. So here I'm referring to, a totalistic lockdown regulations in some instances. Of course, given the situation that we're not necessarily ready, we should think of the strategies we should adopt to ensure we attain the Sustainable Development Goals. At the University of Pretoria, we host the Arua Center of Excellence in Sustainable Food Systems. And as you know, health issues are not divorced from food systems. In fact, good health leads to good nutrition, and good nutrition assures good health, if you like. Over the past 18 months, the Arua Center of Excellence in Sustainable Food Systems has participated in the UN Food System Summit dialogue process. The UN Food System Summit brought together constituencies worldwide, including thousands of youth, food producers, indigenous peoples, civil society, researchers, the private sector, and the entirety of the UN system, to bring about tangible, positive changes to the world's food systems. As these summits go, of course, very good outcomes, but of course not without its controversies. And that is what it is. Out of controversies, you craft better strategies. At the height of the COVID-19 pandemic in 2020, up to 811 million people worldwide faced hunger, a 20% increase in just 1 year. Over 41 million are on the doorstep of starvation. The crisis brought on by the pandemic is unfolding against a planetary crisis that is threatening our climate and life as we know it. The pandemic has reminded us of the interconnectedness of human, animal, and planetary health. This has highlighted the urgent need to enhance cooperation at the national, regional, and global levels to address antimicrobial resistance and zoonotic diseases using an integrated and systems-based One Health approach. A One Health approach is also vital for strong and resilient economies, which takes me back to transdisciplinarity, our mantra at the University of Pretoria. Future Africa, which is the space we are in, has created 5 dedicated professorial chairs, one of which is held by Professor Vanda Makota, who will be chairing a session in the coming days. She's also the director of the Center for Zoonotic Viruses. I want to thank our local organizing committee, headed by Professor Lindiwe Majele-Spanda, which brings in colleagues from the Center for the Advancement of Scholarship, the Faculty of Health Sciences, the Faculty of Natural and Agricultural Sciences, and our esteemed colleagues from the University of the Witwatersrand, otherwise known fondly as WITS. I also want to thank our team at Future Africa who have gone all out to ensure our guests have comfortable accommodation. Here I might be speaking too quickly before I receive the complaints about the state of the rooms. That the meeting venue is top-notch, we hope as usual, and that catering facilities are well organized. Lastly, I would like to thank the academics for their contributions. This is an academic conference of universities that intend to become research intensive and strengthen knowledge creation on the continent. So really at the center of this is not just vice chancellors, it is the academics demonstrating what knowledge that they are producing. I'm told that the highest number of papers are coming from the University of Pretoria. No, that normally I think happens also because when you are the host, and also who knows, I might have sent a threatening email to the academics here. As Vice Chancellor of the University of Pretoria, this is heartwarming because it means we are walking the talk together with fellow Africans. Let me share my vision of what success for this conference would look like. We want everybody to stay healthy, and that is our number one priority. It would be a shame when you live here and then you got COVID, and we're talking about global public health challenges. So I'm assured that all health protocols are in place to ensure this. And if you see anything that is amiss, please do not be afraid to tell the organizers, so we sort it out. Second, I think I want us to a critical analytical understanding of global challenges that leads to pathways to sustainable solutions and Africans as actors on the global stage. I think that's just very, very, very important, that we are able to actually, critically analyze things, create solutions out of that, and solutions that are contextually relevant, globally, contextually responsive, and globally relevant, and that we are actually seen to be agents in our own cause. I would love to see this conference strengthening Arua's ability to co-create and share knowledge through a deeper understanding of transdisciplinarity and how it can enable us to create high quality and more impactful research. Because on the research domain, yes, as Africans, we need to produce more research. We are not producing as much research as other regions of the world, but also the challenge is also high quality research, not just high quantity research. High quality research, and then the next challenge is that very critical last mile, impactful research that actually makes a difference locally and is responsive to our challenges. Thirdly, I would like to see our early career researchers emerge from this conference with enhanced ideas for their research and a clearer sense of their own research trajectories. In addition, more excited about being researchers and the work that they do. I think research must not become a performance contract with the university or the head of the department or the head of the institute. It should be a delight to the researcher because they are creating knowledge and contributing to solutions. Finally, I would like us to adopt an attitude that closer collaboration and deeper partnerships within African universities will give us the critical mass that enables us to scale up and be more locally responsive, globally connected, and engaged to address the challenges of creating more sustainable and equitable futures. Thank you, and I look forward to a fruitful deliberations and knowledge sharing, and again, grateful that to the Arua Chair and our Secretary General for making sure that our organization is able to mount these conferences. I thank you.
Thank you very much to Professor Kupe. We now hand over to the board chair of Arua, Professor Barnabas Nawangwe, who's going to give his remarks and take over as chair as he invites our guest speaker, our host, the minister, and also the keynote address. Over to you, Prof.
Our chief guest, Dr. Matume Joseph Fala, Minister of Health of the Republic of South Africa, represented here by the Deputy Minister of Health, Dr. Sibongiseni Lomo. Our host, Professor Tawana Kupe, Vice Chancellor, University of Pretoria, Professor Ernest Ariete, Secretary General of Arua, Professor Lindiwe Sivanda, Chair of the Local Organizing Committee, all the researchers, participants, ladies and gentlemen. I think Professor Kupe has alluded to Africa's position in knowledge creation. Africa now has 15% of the world's population, but accounts for only 2% of knowledge creation. And many people believe that's why we are lagging behind in development. Many people also believe that Africa is the next growth region of the world. And many of our leaders, including President Mbeki, said that this should be the millennium for Africa. But are we going to get there without research? Research is crucial, and higher education is crucial if Africa is going to change the current situation. Africa is faced by several challenges, and many of them are actually new and increasing. High population growth. It is estimated that in the next 50 years, half of every person living on Earth will be living in Africa. Rapid urbanization, food security, health, climate change, and conflict. It is because of these issues that 18 research universities in Africa came together and said we need to do something about this. We need to change the situation. And hence the 13 centers of excellence, the original 13 centers of excellence. I am aware that the secretariat led by Professor Ariete is doing everything possible to bring partners from around the world so that we can increase this number in order to address our development challenges. So I would like to welcome all of you to this very important conference. I want to welcome particularly our researchers who are doing quite a good job to address these issues. So once again, I want to thank our host, Professor Tawana Kupe. The facilities are good. I have already got comments from my own delegation telling me what I should be doing at Makerere because of what they have seen. We are very comfortable, sir. I want to thank the local organizing committee for the good job done. And also, once again, thank all the researchers and participants for coming to our first physical presence conference since the pandemic started. Finally, I want to thank Professor Ariete and his secretariat for the enormous energy that you are putting in this initiative of Arua. Arua is relatively a young initiative, but we are already seeing a lot of things happening, a lot of partnerships, negotiating partnerships with partners around the world, and that is making Arua stronger and stronger. And I want to believe that Arua will become that vehicle for development of our continent. So thank you, and I would like to wish everybody an enjoyable conference. It is now my singular honor and pleasure to invite our chief guest, Dr. Sibongiseni Dlomo, the Deputy Minister of Health of the Republic of South Africa, to address us. Thank you.
Thank you very much to Professor Nawangwe for calling me into the space to address. And thank you very much, and good morning to the host, University of Pretoria, Professor Kupe. Our sincere thanks to Professor Ariete, the Secretary General of the African Research Universities Alliance, to all the eminent professors, the leadership of our continent that is logged in here, and those who are participating physically in Pretoria. We thank you very much, ladies and gentlemen. I am doing this on behalf of our minister who had other challenges to be here himself. We value this so much. A lot of you are world leaders in research, but the idea of your coming together in the African continent is very heartwarming for us. We are therefore pleased to have been invited to this third biennial conference under the theme Global Public Health Challenges Facing Them in Africa. The National Department of Health recognizes the important contribution that the research community is making in the fight against many other challenges that Africa faces, but in particular this one that we are facing, COVID-19 pandemic. Most notably, research and development has delivered safe and efficacious COVID-19 vaccines at an unprecedented speed. This is a triumph for modern science. However, equitable access to vaccines remains a challenge. Some of the countries in the world are actually getting to close to 80% coverage. In Africa, we cannot talk of the same. Research and innovation work has also helped us deliver various COVID-19 interventions, including one, the rapid diagnostics for use in community settings, the identification of PPE to protect healthcare workers and the public across the world, evidence-based infection prevention and control measures, such as mask wearing and social distancing in healthcare and community settings, better understanding of likely animal hosts for the virus. This will help in future efforts to prevent continued spillage to humans, major clinical trials for the evaluation of candidate therapeutics, evaluating 12 drugs, some of which have proven not to be effective in reducing mortality, and a handful of which has also had positive results. Now, on the COVID-19 pandemic, as of 28 October 2021, more than 2.9 million laboratory confirmed COVID-19 cases have been detected in our country, South Africa, and more than 89,000 COVID-19 related deaths has happened. A total of over 18 million tests have been conducted both in the public and private sector since the start of our pandemic. The COVID-19 transmission is highly clustered, with the majority of transmission events estimated to come from a relatively small number of cases. Transmission mainly occurs among close contacts of infected persons in indoor spaces and can be amplified in enclosed settings with poor ventilation. Secondary attack rates are high in household settings. Between July last year and 30th of June this year, 2 waves of the pandemic swept across the country, and by the 11th of June this year, the National Institute for Communicable Diseases reported that the country had entered the 3rd wave. The 2nd wave was driven by the Beta variant of the COVID-19 virus, while the 3rd was driven by the Delta variant, the most contagious version of the coronavirus to date. These waves resulted in a significantly higher proportions of deaths in the country that would normally have occurred. As a result of this rise in deaths, life expectancy at birth declined significantly. Looking ahead through 2021, substantive epidemiological uncertainties remain, and we hope that you'll actually assist us in trying to unravel some of those challenges. Vaccines are likely to reduce severe disease and death, but their impact on the dynamics of transmission is still largely unknown. The duration of immunity is not yet completely understood. In most countries and communities, natural acquired immunity is low and may wane after several months, and there is therefore still large population susceptible to COVID-19 infection. You probably might have realized that in our country, we took a decision to err on the side of giving our healthcare workers a second booster for the J&J. We don't know whether we are correct, but we hope we are not wrong. We would wait to hear from yourselves to guide us as to what should be the right way to go forward. The variants of COVID-19 are circulating, some with increased transmissibility. However, the preparedness, the readiness, and response to actions that are needed remain the same. Ending COVID-19 pandemic means suppressing transmission and reducing morbidity and mortality through an evolving combination of preparedness, risk management, ensuring the safe delivery of high-quality health services, vaccination and other new tools, and the implementation of public health measures while strengthening public health capacities. On our national COVID health response plan going forward, the overarching aim of South African National COVID-19 Health Response Plan continues to be to suppress the transmission of the virus and prevent associated illnesses and death. As of 2021, the plan was updated to include vaccination as part of the response. I just have 7 points to really raise as our plan as a country. That one, the first one, of course, is to suppress the transmission through the rollout of equitable COVID-19 vaccines through the implementation of recommended, effective, and evidence-based public health and social measures. The second is to reduce exposure by enabling communities to adopt risk-reducing behaviors and practice infection prevention and control, including all avoiding crowds and maintaining physical distance, as I can see in the hall there. Number three is to empower communities to lead and be part of response decision-making processes by reinforcing risk communication and community engagement approaches that can reinforce local solutions, increasing the trust and social cohesion, and ultimately a reduction in the negative impacts of COVID-19. Point four is to counter the misinformation and disinformation by managing the infodemic, communicating with, engaging and empowering communities, while also enriching the information ecosystems online and offline through relevant, actionable and localized guidance that communities and the community taking risk and science for specific target populations as needed. Point five is to protect the vulnerable through vaccination, ensuring vaccine deployment is ready by communicating, implementing and monitoring COVID-19 vaccination campaigns. You probably might have known in our country last weekend, we come from another Vuma. Vuma is both Zulu and Afrikaans word, meaning let's take a very strong drive to really push and vaccinate and be there. So we have Vuma weekends and we want to increase the Vuma weekends going forward. We also want to aim to reduce mortality and morbidity from all causes by ensuring that patients with COVID-19 infections are diagnosed early and given quality care and treatment in a COVID-19 care pathway with access to corticosteroids and oxygen for patients with severe diseases. That health systems can adapt to maintain and meet the increasing demand for both COVID-19 care and other essential healthcare services, the core health systems to be strengthened, because we need to look beyond just COVID-19 going forward. That demand side barriers to care are addressed, and by ensuring that all priority groups are vaccinated. The last point is to accelerate equitable access to new COVID-19 tools, including vaccines for the whole of Africa, diagnostics and therapeutics, and support safe and rational allocation and implementation. South Africa is currently observing a sustainable decrease in the number of new COVID-19 cases, and all provinces have exited the third wave. There's an overall decrease in hospitalizations and deaths in our provinces. And we would like to therefore wish you well in the deliberations, and we are looking forward under the leadership of Minister Pasha to receive your deliberations and be enriched, because if we do have researchers in our continent, in the world, who are actually getting their research work done and engage the government, the policymaker to say, this is our view as researchers, this is our view as scientists, we will really be able to take our country forward. We cannot do it all by ourselves. We need our researchers, we need our scientists to guide us. Have a good, fruitful day. Thank you very much.
Thank you very, very much, Honorable Deputy Minister of Health for South Africa. Thank you. We now go to our first keynote address to be delivered by Professor Salim Abdul Karim. Professor Salim Abdul Karim is Director of the Center for the AIDS Program of Research in South Africa, CAPRISA, and CAPRISA Professor for Global Health at Columbia University. He is an adjunct professor of immunology and infectious disease at Harvard University, adjunct professor of medicine at Cornell University, and Pro-Vice Chancellor Research at the University of KwaZulu-Natal, South Africa. He is a member of the WHO Science Council. He is the chair of the WHO Strategic and Technical Advisory Committee for HIV. He is a member of the Africa Task Force for Coronavirus and the Lancet Commission on COVID-19. He is a fellow of the Royal Society. Please join me in welcoming Professor Salim Abdul Karim, who will speak to us from Tokyo.
Thank you very, very much. Indeed, it's a great pleasure for me to be here with you here today. I'd like to start by acknowledging and thanking, let me just set this correctly, my apologies. Right, thanks. Let me just see here. Thanking Professor Subanda, Arate, Kupe, and Wangwe for this morning's session, and I want to acknowledge all their contributions. I noted that my good friend, Dr. Tlomo, stood in for my fellow classmate, Dr. Pashla, this morning. I want to share with you today global public health challenges. And I'm going to talk about it. I'm going to give a brief overview, talk about incidents because the organizers asked me to focus on it. But I'm going to use, towards the latter part of my talk, I'm going to be using COVID-19 to illustrate some important lessons that we have. So let me plunge directly into my talk. I'm going to give a brief overview of public health challenges globally and the way in which they impact Africa. I'll touch on the changing profile of diseases. I'll touch on Africa's disease burden and how it differs from the global burden of disease. I'll talk about the disproportionately high disease incidence, and I'll end off touching on epidemics in Africa. I'll then talk about the role of science. In today's forum of Arua, I couldn't let that go by. I had to come to grips with giving you some impressions that I have of the way in which we can face these global health challenges with the weapon that we have. And that is our computers, our data, our papers, and our science. I'll go then to using SARS-CoV-2 as an example of some of the challenges, and I'll end off with looking ahead, 3 key lessons that we can take forward. So let me plunge directly into the changing profile of global health challenges. Now, if you just look at the 2 sides of this slide, on the left-hand side, those are the 15 top causes of disability-adjusted life years in 1990. Fast forward 30 years later, on the right-hand side, those are the leading causes of DALYs, disability-adjusted life years. So that's about disability and death on the right-hand side. Now, I want you just to eyeball these 2 sides, and I want you to particularly focus on the way in which the dominance of orange on the left-hand side is now lost in the right-hand side. So just at a global level, that's the thing that hits you first. So if you look at in 1990, the number 1 cause of death and disability was respiratory infections and tuberculosis. And the second was maternal and neonatal causes. And when you get to 4th and 5th, enteric infections and so on. Now, 30 years later, cardiovascular diseases have become number 1, neoplasms have become number 2, and maternal and neonatal have now moved to number 3. And of course, respiratory is now gone all the way down to number 5. So what we are seeing is the global transition in health. And a lot of this is being driven by developing countries, or what is usually referred to as lower and middle income countries. And so this changing profile means that as scientists, we have to ensure we are monitoring this change, we are adapting to this change, and we are addressing this change. Let's go to Africa. So that was the global burden of disease, which I've now captured slightly differently in the top graph. So on the top graph, what you're looking at is the global burden of disease in 2017. And again, cardiovascular disease, cancer, neonatal disorders, the same order that was in the previous slide. Now, if you look at the bottom graph, that is the burden of disease in sub-Saharan Africa in 2017. The picture is different, dramatically different. You see neonatal disorders is now number 1. Malaria and tropical diseases become number 2. So we need to be cognizant that while the world is focusing on the top set of priorities, in Africa, we have a different set of priorities. Our different set of priorities within the African continent needs to focus because of the huge impact that if you look at the first 2 conditions on this list are contributing. So we need to be cognizant that we have a different set of priorities and that we have to focus on them because no one else is going to focus on their priority for somebody else. And if you look at the fact that it's not just that we have a different burden of disease, this map of the world showing the burden of disease makes it very clear that if you're looking at Africa, it has a disproportionately higher burden of disease in Africa. So we are looking at a different burden of disease, we're looking at a changing burden of disease, and we're looking at a much higher burden of disease in Africa. Let me use South Africa as an example. This is a fascinating set of analyses that was published in The Lancet. It provides the burden of disease across the world for each country. And you can see the dominance of India in this equation. And the color scheme for what's contributing to the burden of disease in each country is shown by the colors, and here's the legend. Now, when you look at India and the fact that it contributes 22% of the entire burden of disease in the whole world, and Nigeria coming in next at 9%, I want to just draw your attention to Bangladesh. Bangladesh contributes about 3% of all the burden of disease in the entire world, but it has a population of 153 million. You compare that to South Africa, which also contributes 3% to the global burden of disease. We have a population of only 48 million. Well, this was at the time that the study was done. We'd now have to increase that to about 60 million. Now, if you look at that distinction, it just gives you some idea of South Africa having to cope with almost 3 times the burden that Bangladesh, and Bangladesh is already carrying a high burden, but it's giving you some idea of that disproportionate burden. And of course, within South Africa, HIV/AIDS is a major part of that, as it is in most of the countries in Africa. So when you look at the Democratic Republic of Congo, Ethiopia, Tanzania, you can see how HIV has influenced that, and treatment rollout is now starting to impact on that. So there's a changing profile in that regard. But it's quite striking that we are looking at such a high burden of disease in much of Africa. And if you look at South Africa, we've described it, probably most easily described as, or simplistically described as, the quadruple burden of disease. That we have these 4 colliding epidemics with very substantial contributions to the burden of disease in South Africa, whether it's maternal and newborn child health, or non-communicable diseases, or violence and injury, or infectious diseases like HIV and TB. So that means that we're having to deal with all of the challenges of being a lower income country, that you would see this kind of profile, but we're also dealing with some of the challenges you see in higher income countries with the growing burden of non-communicable disease burden. So that's just a reflection of the state of transition that we are in, this epidemiological transition. As we move through this transition, this balance between the four we expect will steadily change. But I want to just touch on one aspect, and that aspect is the way in which sub-Saharan Africa has a disproportionate number of epidemics. And if you look at this, a map of Africa, the color of blue indicates the number of epidemics in each of these countries over a 3-year period. And if you just think about, in South Africa, we've had to deal, not just with TB and HIV and so on, we also, have to deal with listeriosis outbreaks and so on. So the point I want to make is that the situation in much of Southern Africa is not just that we're dealing with long-term challenges in infectious diseases, we're also dealing with acute epidemics as we look at in each of these countries. So the demands and the needs that we are facing is a changing demand, a changing set of needs, but we need to factor in the very specific needs that we face, particularly as far as epidemics and infectious diseases are concerned. And if we just take one of those infectious diseases, the COVID-19, we have some idea of its impact. And that many are saying, oh, Africa is not really being impacted. Well, we have 8.2 million reported cases, the actual number of cases through serology being many times that, up to about 20 times that number. And of course, we've had a very sizable number of deaths. We estimate that in Africa, roughly about 1 out of 4 deaths due to COVID are being reported. So the actual number of deaths is closer to 1 million. But it gives you some idea that, within the short space of time, the whole of Africa has dealt with a first wave, a second wave, and a third wave, just like we've had to deal with in South Africa. So let me go on, now that I've given you a perspective, just an overview of the public health challenges at a global level and in Africa, and the way that is changing, and the disproportionately high burden that we have to deal with, especially with regards to the high disease incidence and epidemics. Let's talk about facing global health challenges with science. And here, again, I'm going to use COVID-19 as an example to illustrate it. So we know that we have a task, and our task is to achieve the Sustainable Development Goals. And in the field of health, we are particularly focusing on SDG 3, which is to ensure healthy lives and promote health, promote well-being across the different ages. Now, we know we've been set back. The pandemic has, lowered life expectancy because of the large mortality we've had to deal with. It stalled some of our progress. It's highlighted the challenges we have in terms of access to care, the importance of good surveillance and data, and the need for having a healthcare workforce. So all of these have been, really spotlighted by COVID-19, and we've got to tackle all these challenges, and we have science on our side. So when we think about the fact that the first reported cases of unknown pneumonia that we saw, that was brought to our attention at the end of December, on the 30th of December, that within 11 days, we had the sequence of the virus. And I first learned about it on Twitter. I mean, never in my life have I seen a major scientific discovery on Twitter. In fact, I didn't even have a Twitter account at that time. So I didn't even know what Twitter was. But that's how information needed to be shared very rapidly with the world. And the WHO declared SARS-CoV-2, didn't have a name at the time, it was just called novel coronavirus, a public health emergency of international concern. And when I was asked, back in May, June last year, when are we likely to see a virus? I said, a vaccine. I said, well, I've been working on HIV vaccines for 33 years. So I don't think we're going to see a vaccine anytime soon. Well, I was dead wrong, because on the 9th of November, Pfizer, with their partner BioNTech, announced the first results of a successful vaccine trial for SARS-CoV-2. And it was an international consortium that made that possible. We sometimes forget that the world had to come together across all these different countries, the US, Turkey, Germany, South Africa, Brazil, Argentina. This trial was done across all of these countries. And from those early results that we heard, I mean, today we have a whole panoply of different vaccines. All have been shown to be effective. And indeed, this is one of the great accomplishments that we have seen in COVID-19, and the role of science in transforming this disease from one where we had to just deal with endless waves to one now that we have an armamentarium against it. But we've also seen scientific innovations in diagnostics. On the left-hand side, you're looking at my laboratory. When I initially converted in February last year, my HIV PCR laboratory to testing COVID-19. And of course, now I'm just coming back from the Pasteur Institute in France. I mean, everywhere in France you go, they have these little boxes. It's a take-home test, a rapid antigen test, which is pretty accurate. And so we now are having tools that make diagnosis so much easier, that you can know whether you've got SARS-CoV-2 within a matter of 10 minutes. We've also had major scientific innovations in treatment, right? From the initial recovery trial that showed that dexamethasone reduced mortality in late disease by about 30%, to the two exciting trials that we saw, providing us with the data on tocilizumab and on the combination Regeneron antibodies, and to our most recent results, where we've seen the Merck announcing the results of molnupiravir, and then most recently, in the last week or so, Pfizer releasing their results on Paxlovid. But importantly, science has also provided us with the evidence and the compelling evidence that we've got a whole lot of other medicines that simply don't work. Azithromycin, interferon, hydroxychloroquine, ivermectin, vitamin C, convalescent plasma, Kaletra. So all of these have been tested in randomized controlled trials repeatedly, and now we know that they don't work. And so we can consign them to the dustbin of treatments for COVID-19. Though I have to tell you, there's a whole group of medical practitioners, very sadly, that still punt some of these treatments, including hydroxychloroquine and ivermectin. In fact, there's a whole group of people, if you dare to say anything against ivermectin, expect to get hate mail. Well, I thought I would just touch on what for me is going to be a game changer. I anticipate that these two new drugs, they are Merck's molnupiravir and Pfizer's Paxlovid, they are going to change how we look at COVID-19 because of their dramatic impact. And I've just seen the results of the move in and the move out trial of molnupiravir. It's impressive. When you take that, in these trials, there were 0 deaths on patients on molnupiravir compared to 8 deaths on the patients in placebo. And similarly, if you look at Pfizer's Paxlovid, there were no deaths in the Paxlovid group and 7 deaths in the placebo group. So, I mean, this is not definitive evidence that there'll be no deaths, but certainly the deaths will be dramatically lower, expecting them to be about 90% lower. So that means that we now have a cascade to deal with COVID-19. We have a cascade in that we have our public health prevention measures, we have our vaccines to reduce our risk. But even if the virus can break through all of those interventions and you get the infection, we now have the basis on which we can reduce your risk of being hospitalized quite dramatically with these drugs. So we are adding to an armamentarium that's going to enable us to move to a situation where we'll regard SARS-CoV-2 as just another infection that if you do get it, take your tablets and you should be okay. Just like the way, we converted dramatically a disease like HIV that was uniformly fatal to one now where you can get antiretroviral treatment in the most remote village in Africa because of the way in which we have rolled this out through international solidarity and all of that. So let me go next to SARS-CoV-2 and touch on just the way in which this wily enemy has been looking for opportunities to mutate. So we know that initially we were seeing the ancestral strain. That's the strain that originated in Wuhan. But very rapidly, estimated somewhere around March of last year, the ancestral strain developed one new mutation, mutation at position 614. And that's the mutated virus. The D614G variant is the one that spread throughout Europe. Of course, because the virus entered South Africa from Europe, the first cases were from Italy, but most of our cases actually come from the UK, we acquired the D614G variant. And for many months, we were looking at this virus, and every month, Professor De Oliveira, whose laboratory is one floor below mine, would share with me his results, and we say, oh, the virus is not changing, virus is not changing. Well, we got a shock in November last year when we saw the virus change. But it wasn't changing in a little way. It was changing dramatically, creating a whole new variant. And so we began to see the creation of new variants. So the UK announcing the Alpha variant, we announced the Beta variant, the Gamma variant from our colleagues in Brazil, and then finally India reported a new variant in March last year, which they called the double mutant, which we now refer to as the Delta variant. And we don't yet know what's the next variant. So why are variants important? They're important for the fact that they have a major impact. So what I'm showing you here is the first wave in India, in Brazil, and in South Africa. And you can see India had a very mild first wave. In fact, their politicians were saying, oh, they've conquered this virus. Brazil had a horrible first wave, and South Africa, we had quite a significant first wave. But if you look at what the variants have done, well, the Delta variant had a dramatic impact in India. And those heart-wrenching pictures you saw on your television screens of the way in which it impacted the situation in India. The Gamma variant impacted Brazil, and in South Africa, we had the Beta variant driving the second wave and the Delta variant driving the third wave, as Deputy Minister Dlomo had pointed out. But what is interesting is the way in which each new variant is beginning to dominate and out-compete the previous variants. So the new variants are not coexisting with the old variants. They are wiping out the old variants. So if you look at D614G, the Beta variant literally just overtook it within a matter of 2 months. Now, there was still some D614G floating around, some of it through reintroduction. And as one of the challenges we saw to Beta, Alpha decided to come along. And it was mainly because we eased restrictions and people from Europe were coming into South Africa, and they brought Alpha to our shores. Alpha started spreading, but really in this blue sliver didn't have much chance. The reason it didn't have much chance is because Delta arrived. And when Delta arrived, it literally displaced everything. It is so much more transmissible that it gave no other variant any chance to spread. So today, we are almost at 100% of Delta variant. In fact, it's just well over 90% in all the different forms of Delta. But we have to expect that there may be more variants. And here, I'm sharing with you a paper that's just come out in the New England Journal of Medicine. And this is from Colombia in South America, where a variant called Mu has displaced both Delta and Gamma. So look at this picture on the left-hand side. The light yellow is the Gamma variant, and South America is dominated by the Gamma variant. The Gamma variant is not is pretty similar to the beta variant, by the way. And you can see how the gamma variant was trying to take a foothold. But in the blue, you can see the mu variant was just not letting it take over. It wanted to hang around. And in fact, after a while, it started diminishing the amount of gamma variant, and mu was becoming the dominant variant. And along comes Delta. And of course, Delta outcompetes almost anything. And what you see is in the orange, the way in which Delta was rising, but mu will have none of it. And so mu was able to compete Delta even in Colombia. And if you look on the right-hand side, you can see that this low blue bar indicates that if you've had past infection, you would have very little protection against the mu variant. And even if you took the Pfizer vaccine, you would have very little protection against mu. So it's just giving you some idea that there are variants around. And, fortunately, mu doesn't look like it's spreading beyond South America. But we have to be vigilant, and we have to expect that the next variant, there's a reasonable likelihood that the next variant will have an increased risk of immune escape. As we've seen with the way in which the clinical efficacy of some of our COVID-19 vaccines have been impacted in the past. The AstraZeneca vaccine, which was 70% effective against the D614G variant, was only 10% effective against the beta variant. Basically, the D614G virus was easily neutralized by antibodies and the immunity generated by the AstraZeneca vaccine, but not the beta variant. However, what we see with the Delta variant, that it maintains quite a lot of its efficacy, between 50 and 60% efficacious against Delta. If we look at the Pfizer-BioNTech, which is a much more efficacious vaccine, very high efficacy against D614G. It's also very high efficacy against the beta variant in South Africa. But against Delta, it is being tested. It's now come all the way down to between 64% and 87%, depends on which country's data you look at. So what we are seeing is that our vaccines, even our highly efficacious vaccines, that to some extent they are not able to protect as well against new variants. So the variants have changed the game. They have changed the end game for COVID-19 in that we now have a better understanding of each of these variants. We're getting a better understanding of their public health impact, their vaccine implications, and we have a better understanding of what it's going to take to end the pandemic in the face of these variants and the importance of correlates of protection. But one of the challenges we are experiencing is self-interest and the way in which self-interest is impacting at the expense of pandemic control. And that's in particular when you look at vaccine coverage. In Africa, it is quite disturbing to see the low levels of vaccine coverage. So while at a global level, just over half of the world's population has been vaccinated, in Africa, it's still around 5%. That is really unacceptable because it's indicating that we are now at risk if a new wave comes along, that we will see the virus continuing to transmit. And we have as much impact from COVID-19 as every other country has had. We have deaths, we have the impact on the economies, so we have to do better. We have to get the doses, and we have to get them despite the challenges of the way in which developed countries are buying them up and hoarding them. So let me end off with 3 key lessons in my remaining 4 minutes. So the first is that the first lesson I want to share, pay attention to the warning signs. SARS-CoV-2 is not the first coronavirus from a horseshoe bat. A horseshoe bat created the first SARS pandemic. Well, it was an epidemic, at least in China, where a coronavirus from a horseshoe bat through civets entered into humans. We don't care much about horseshoe bats, and we don't care about their coronaviruses because their coronaviruses can't infect humans. But once they go through an intermediate host, they acquire the ability to attach to the ACE2 receptor. And when they do, they then begin to impact humans. But if that wasn't enough in 2003, barely a decade later, we had MERS, where another coronavirus from a horseshoe bat, this time going through camels, begins to infect humans. And now we know, of course, that about 8 years later, we've seen SARS-CoV-2 and its impact. Pay attention to warning signs. The second is be prepared. The best way to deal with a pandemic is to prepare for the pandemic. I remember back in the 1990s, early 1990s, when I chaired the National Advisory Group on Immunization, we prepared South Africa for a flu pandemic. Professor Shub, myself, and others were busy putting all our plans together for flu. We were stockpiling the treatments that were required because we said, we're never going to get amantadine when there's an actual pandemic. We've got to buy it ahead of time. And so we did all of that. And of course, there was no flu pandemic. There were several threats that there would be a flu pandemic, avian flu and so on, but we just never had it. And so we became complacent. Well, we can't. We've got to be prepared. I think the coronavirus is a lesson for us that we have to expect more coronaviruses and flu pandemics and others. Remember, horseshoe bats have thousands of coronaviruses. So let me end off with my last lesson, and that's the importance of mutual interdependence. Now, having worked in the HIV field for over 3 decades, let me just quote from this document by UNAIDS, how AIDS changed everything. And I quote, "The AIDS movement demonstrates that with a shared vision, shared responsibility, and global solidarity and the leadership of people living with HIV-affected communities and individual action, we can change the course of history." And I've already given you the example of how we've changed the course of history with HIV from making it, a uniformly, easily manageable condition across the globe. And we did that partially because of this global solidarity in the form of the Global Fund, UNITAID, PEPFAR. We understood that the way we were going to deal with HIV is we're going to deal with it all together, that rich countries would help poor countries through this global fund. We tried to do the same in SARS-CoV-2 through creating COVAX. We understood the need to come together, but COVAX failed. It failed because too many rich countries were not willing to be part of an equitable solution. They wanted vaccines first, and they wanted the lion's share of the vaccine. In fact, by May of this year, over 50% of the world's stocks of vaccines were being held by just 15% of the world's population. And that gross inequity is what has created this challenge. And I want to congratulate Arua for rising to that challenge of understanding that no country can deal with this pandemic alone or deal with many of the scientific challenges we face in Africa. As we deal with each of these public health challenges, it is the strength that we bring by standing together that will enable us to take on this challenge, because we have to avoid this problem that we are seeing in the way in which mutual interdependence has failed us in the field of vaccines, that we have dire shortages of vaccines in Africa. The current estimate from the WHO is that we have a 470 million dose shortfall in 2021 for COVID-19 vaccines. And COVAX, which is the main deliverer of vaccines in Africa, simply cannot meet its delivery targets. Why? It's not that it's asking for donations, it's buying vaccines. But who controls who gets vaccines? Well, pharmaceutical companies are determining that, and they want to protect their markets. So Israel decides it wants to give a booster dose to its entire population, so it can get vaccines immediately. South Africa, that had bought 20 million doses of Pfizer vaccines before Israel decided to give these booster doses, we were waiting. No doses available for South Africa. We're very sorry. You go to the back of the queue. That has got to be changed. In the midst of all of this, of course, the US has so many doses that it can't even give them out at the moment. And so we're seeing millions of doses being expiring and being destroyed. And so this dire shortages in the midst of the glut of vaccines is something we're going to have to undo. It is our mutual interdependence that we are going to have to deal with. And I want to just end off with very quickly give you a perspective of what this need for us to stand together means by sharing with you this WHO short clip on putting out a fire.
Imagine there's a huge fire burning through a big city. It's getting bigger and bigger, spreading all across town, through the rich areas and the poor areas. People in the richest neighbourhoods buy up all the fire engines, just to put out the fire in their own neighbourhoods. Now there are no fire engines in the rest of the city, and so the fire spreads. Soon, the fire is surrounding the rich neighbourhoods, getting bigger and bigger. No one is safe until we're all safe.
So I hope I've given you just a sense of the challenge and the importance of what ARUA stands for as we stand together to take on the challenges of global health problems that we face right here in Africa. Thank you very much.
Thank you very much, Professor Salim Abdul Karim. I think he deserves a bigger hand clap. I don't think that there could have been a better keynote for this particular conference. And as you are aware, Africa, as he said, is assumed it may not have been devastated so much, but even with the little effect, it is affecting our countries, our economies, very seriously. I do hope that his address has made you African researchers angry. Angry that we have not been able to do something. Angry that we were basically abandoned to fate. And that anger should translate into something. To determination that we must change the situation on the African continent. Thank you once, Professor Karim. That brings us to the end of the first session, and I think we now proceed to a health break. Thank you. 15 minutes health break.
I was saying that in view of the delays that we've had, it would be proper for us to shorten our comfort break by another 15 minutes. So instead of 30 minutes as in the program, we are taking only a 15-minute break. It's now 10:25. We should be back by 10:40. Yeah. Welcome back, ladies and gentlemen. We are about to have our first plenary session, which will be chaired by Professor Margaret Jason Hutchinson. She is the Associate or Deputy Vice Chancellor Research, Innovation and Enterprise, and also a full Professor of Horticulture at University of Nairobi. She is representing the Vice Chancellor of the University, Professor Stephen Kiama, who was originally scheduled to chair this session. Professor Hutchinson has extensive experience in research and administration at the University of Nairobi. She's a regional trainer and facilitator on food security. She has published widely in agriculture, food security, and gender. So, Professor Margaret Jason Hutchinson.
Thank you very much, Professor Yete, and the previous speakers who have spoken. We just ended the first session with a keynote address from Professor Salim Karim, who gave us an overview in terms of the public health challenges and the disease burden globally, but also touching on Africa and how science then intervened, and we got the first vaccine for COVID-19 in the shortest time possible. He also indicated that in the process of addressing the issue of COVID-19, we got a lot of variants that then complicated our interventions. He finished by giving us 3 key areas where we need to focus going forward, with a clip that you cannot put away a fire or put out a fire by just dealing with half of the house. So this first plenary session has a theme of understanding the changing dynamics of global public health issues and coming down to applications of Africa, or to Africa. In this session, we are going to have 3 speakers. I'm told all of them are virtual. And so our first speaker to address the issue of beyond COVID-19 routine immunization in Africa is Professor Helen Rees from the University of Witwatersrand. Professor Helen Rees is the Executive Director at RHI, University of Witwatersrand. Professor Rees is the Executive Director, as I mentioned. She chairs the board of the South African Health Products Regulatory Authority and also chairs the World Health Organization's Afro-Region Immunization Technical Advisory Group. She has extensive involvement in national, regional, and global response efforts to COVID-19, including the development of COVID-19 vaccines, their potential rollout, and utilization. She is also a member of the South African Ministerial Advisory Committee on COVID-19 and a member of the South African Ministerial Advisory Committee on COVID-19 vaccines. She chairs the South African VACMAC COVID-19 Variant Technical Working Group and is a member of the South African National Essential Medicine Committee on COVID-19. Indeed, Helen is involved with the oversight of the COVAX facility that Gavi, KEPI, and World Health Organization are jointly driving. She is a member of the COVAX Committee on COVID-19 maternal immunization and a member of the WHO IHR Emergency Committee on COVID-19. She is a member of WHO Expert Committee on COVID-19 vaccines and a member of the WHO's Scientific and Technical Advisory Group on Infectious Hazards. Helen has chaired the WHO's International Health Regulation Polio Emergency Committee since 2014 and co-chairs WHO SAGE Working Group on Ebola Vaccines. Helen is a member of the Global Alliance for Vaccines and Immunization Board and chairs the Gavi Program and Policy Committee. She is a member of the Coalition for Epidemic Preparedness and Innovation Board and chairs the KEPI Scientific Advisory Committee. Ladies and gentlemen, let us all welcome Helen Rees to give us her presentation. Thank you.
Professor Hutchinson, thank you very much for that introduction, and to Honourable Deputy Minister Dlomo, if he's still with us. Thank you so much for the ministerial presence at such an important conference. And to all my colleagues, Tawana Coupe and Professor Sabanda, and all the colleagues who have put this important conference together. So you'll see that I put in the program routine immunization. But there's nothing routine about immunization. And this is what I'm going to try and show you in this talk. I'm rather going to talk about essential immunization strategies in Africa. And I will refer to COVID, but Slim has done such a great job. We decided that I'm going to sort of think about the other things that we need to think about in our region. So Mark Twain said something very memorable. History may not repeat itself, but it sure rhymes a lot. And in this talk, I'm going to talk about lessons learned from smallpox, polio, Ebola, malaria, and how that comes to what we now call zero-dose children. For the young scientists and researchers here, I'm going to come back to this slide. You'll notice it's empty, so see if you can remember the list of lessons learned on the side. But I'm trying to take out what we've learned over history with rolling out these vaccines. And I'm going to start with smallpox. So smallpox has been eradicated, as you all know. And how did they do it? Well, they did the first really comprehensive set of surveillance with monthly surveillance worldwide. And in 1969 in Brazil, in a state of 7 million people, they changed their strategy. They found index cases of smallpox, and then they vaccinated everyone around that index case, which meant that they only had to vaccinate 50,000 people to eliminate smallpox from that state. This is the ring vaccination strategy. And I'd like you to hold on to the thought of ring vaccination strategy, because I'm going to come back to it. The last naturally occurring case of smallpox we had was in 1977 in Somalia in the African region. And the world was then declared smallpox-free in 1979, a huge achievement, but it's the only time we've managed to eliminate a human pathogen of this sort. If we look at what was happening around 1979 in this chart from WHO in 2003, if you look at 1980, you can see that the coverage of other vaccines here was very, very low. BCG, diphtheria, tetanus, pertussis, all of these vaccines had very low coverage at this time. And the world had woken up to the importance of vaccination because of smallpox. So on the route to smallpox eradication in 1974, WHO established the expanded program on immunization. The expanded program on immunization aimed to vaccinate children initially with 6 vaccines, TB, diphtheria, tetanus, and pertussis. And it's been a very successful program, but we're going to come back to that. Part of the success was then attributed to Gavi, the Global Alliance on Vaccines and Immunization that was established in 1999 to support the poorest countries who were having the most difficulty in getting programs off the ground. The accepted understanding is that vaccination worldwide today is the most cost-effective of our health interventions, saving between 2 to 3 million deaths annually. And I know that in this program, we're going to come back to vaccination research. And now you can see for this region why it's so important. So we've been successful with an eradication target once. But if you think about the expanded program of immunization, your first prize is indeed to get rid of these pathogens and these diseases, not to keep immunizing people forever. And so the world then said, what's our next target? And the next target was chosen to be polio. Polio has been a dreaded disease since the early 1900s and before. And in the 50s and 60s, we saw the development of the first polio vaccines, which really changed the face of polio. And it got the world excited. So by the 1980s and 90s, there was a global discussion that we could indeed eradicate polio after eradicating smallpox. In 1990s, Nelson Mandela became a champion for the eradication of polio from the African region. So let's just think about what we've learned about polio eradication. And you'll see that I've said for 2000 and 2010, it's one step forward or one step back. And then now the final stretch. What have we learned? Well, look at these figures. Polio paralyzed children from 1985, you could see was up to 400,000 worldwide. This was a really dreaded disease. It killed, it paralyzed, it maimed. And it was seasonal and it came back into even the richest countries. But you can see with the introduction of vaccines that we started to see a decrease. And we've now seen a decrease in wild polio virus of over 99% worldwide. For the African region in 1965 in the yellow, these were the reported wild polio cases. And for sub-Saharan Africa, every single country had wild polio. But in 2016, we were able to declare that we had eradicated wild polio virus from the African region. So good, so far, so good. But this is the one step forward, two steps back dilemma. We've eradicated wild polio virus type 2 and 3 worldwide, but we still have type 1 wild polio virus, which is endemic to two countries now, Pakistan and Afghanistan. And the last African country that had wild polio virus was Nigeria. We've achieved this incredible decrease in wild poliovirus by the use of the oral poliovirus vaccine. But what have we now seen? So this is a little bit complex for people not familiar with this speak, but we've seen increasing numbers of what we call vaccine-derived poliovirus outbreaks. And I'll explain why we're seeing those. And most of those are vaccine-derived poliovirus type 2. And we're seeing global spread, and we're seeing global spread, especially in sub-Saharan Africa. So while poliovirus is going down, but vaccine-derived is going up. Now, why is that? So in under-immunized communities where they're not getting any polio vaccinations, what the oral poliovirus, which is a weakened, attenuated virus, can do is it can circulate in sewage and through populations of people repeatedly. And by doing that, it can genetically revert into a form that can cause paralysis very similar to polio. And we call that circulating vaccine-derived poliovirus. This was enhanced because in 2016, in order to get rid of this risk, we actually replaced the trivalent oral poliovirus. We took out that type 2 and we left it ourselves with only type 1 and type 3. So we thought we would avoid this. But what we did was created lots of children who are not protected against this vaccine-derived poliovirus. So what does that mean? So you can see in the chart on the right how these numbers of what we call CVDPV2, try saying that quickly. It's a mouthful, but you can see those numbers since 2016 when the trivalent was removed, the trivalent vaccine was removed, those numbers are going up and up. How have we responded? This is important in lessons learned. We've introduced inactivated polio vaccine into routine immunization programs. We did, but then we had a shortage, a global shortage. So, one step forward, one step back. We've introduced for outbreaks of vaccine-derived poliovirus, the monovalent OPV2, to address that particular circulating virus. But that also isn't very stable, and that can also get into circulation. So now we've developed a new vaccine, which is a type 2, what we call a novel OPV2 vaccine. And that is what we're now starting to introduce into countries with these outbreaks. But the other thing is in addition to needing new vaccines, remember this is an old disease and we've had vaccines since the 1950s and beyond. We needed new vaccines to solve this problem, but we also needed new vaccine strategies for hard to reach areas and conflict zones. So look at this map from the last 12 months. So in the previous 12 months, you can see in red, the red dots, the numbers of wild poliovirus type 1 cases. And you can see that it's Afghanistan and Pakistan that are endemic. And obviously, in some of these areas, very hard to reach populations. But you can see in the last 6 months, we have seen no cases of wild poliovirus in those two countries. So we're getting very excited that we might be on path to eradication of wild poliovirus. But look in the green dots. These are the vaccine-derived poliovirus outbreaks that we're seeing. And they have spread from country to country. And you can see that the large numbers we saw 12 months ago have reduced, but they're still in quite hard to reach areas in our region. And we need to do a lot more in terms of being able to access particularly the children and communities where we're still seeing this vaccine-derived poliovirus circulating. Let's look at the lessons then learned from Ebola. And I'm sure many of you remember this terrible outbreak that we had. So the first case of Ebola was seen in 1976, but since then we've been identifying Ebola outbreaks. And the most common outbreak with the Ebola type that causes the most severe disease is the Zaire. But there are 4 types of Ebola known to cause disease in humans. But you can see here that the Zaire outbreaks are the ones that have really caused a problem. And in 2014, we had a huge, unprecedented outbreak in 3 West African countries. It resulted in over 11,000 deaths, and very likely, and there'll be more discussion of this in this conference, African fruit bats were likely the source animal. Why did this happen? Why did this suddenly happen? Partly because we're seeing this rise in zoonotic diseases jumping from animal reservoirs into humans, but why else? We had weak surveillance and a weak response initially, that candidate vaccines that might have helped were sitting on shelves, that there was no commercial interest. There's very little interest in developing a vaccine for outbreaks in poor countries. That there was no consensus on clinical trial designs for an Ebola outbreak. Remember, when you have an outbreak, you've got to get into the field, whatever that outbreak is, very quickly to assess whether your vaccines work or not. There were delays in getting these trials into the field as a result of this. Weak regulatory authorities in the countries, but across the region. Little investment in regional research, as we've heard from earlier speakers, very little investment into research infrastructure and into our researchers. And so we ended up with 1 successful vaccine trial. This was called Ebola Sasufi, and it took place in Guinea. And the primary outcome was to look at vaccine efficacy against confirmed Ebola disease. There were secondary outcomes looking at vaccine effectiveness, vaccine efficacy against death, vaccine efficacy against suspected or probable disease, and then looking at safety. What happened with that? Well, first, what did they do? Very important, and I told you to remember smallpox and ring vaccination. They went back and said, what do we do for smallpox? Remember that Ebola is a disease of contact and bodily fluids. So they did what was done for smallpox. They found an index case. They vaccinated with a single dose of the RVSV in this study. It was a single dose schedule. They vaccinated contacts and then the contacts of contacts, household members, community members, people who'd visited. And they vaccinated healthcare workers who'd been in contact. And this was the one study at that time that was able to show a reduction in mortality by using this ring vaccination approach with the RVSV vaccine. The people who received the vaccine early in those rings had no deaths, whereas those who received it 2 weeks later, there were 16 deaths recorded. And this changed the face of these outbreaks. What do we currently recommend? We recommend that if there is an outbreak, we use the RVSV ZBOF Ebola vaccine in a ring vaccination strategy, plus we look at the healthcare and frontline workers most exposed. Gavi now has a stockpile of this vaccine ready for outbreaks. And we're now considering the use of new vaccines. There are new Ebola vaccines being developed. One is based on an Ad26. You'll have heard that expression used a lot for COVID vaccines as well. It's a 2-dose schedule, so it's not suited for an acute outbreak, but it can protect people who might be at high risk in areas prior to an outbreak. And we always remember the importance of communication. If you remember, funeral rites and traditions were one of the main drivers here. So communication was key, and the public health prevention measures are key. Sounds like COVID, correct? What we also are seeing, just as we saw for polio, is that we're not stopping. We're still trying to have new vaccines and better vaccines. Remember that the RVSV is only active against the Zaire type of Ebola. And so now the Oxford team are looking, using the ChAdOx approach, similar to the one they've used for the COVID vaccine they developed. They're looking at developing this to attack both the Zaire and the Sudan strains of Ebola. Let's then move on to another huge killer, malaria. I think I'm talking to everyone who knows this, but if you look at the global burden of disease, the highest burden of disease here, see these malaria cases in green are in the millions, is in the African region. Every year, this astonishing figure, 265,000 children under 5 die in our region. This is from 2019, and it's a disease of poverty. We have prevention tools, but they're not perfect. Insecticide-treated nets give about 40–50% protection. Residual spraying indoors is about 15%, and intermittent preventive treatment about 70%. So we've got a number of prevention tools, but we're still seeing we've got stuck. You can see we've plateaued with the numbers. So we've been trying to find a vaccine for 30 years. Backtrack to Slim's talk about, the 9 months it took us to develop a COVID vaccine. 30 years. From 1984 in the discovery phase, through to the results of a phase 3 trial in 2015 and a pilot study in 2016 for a huge global killer. The results of that phase 3 trial for this RTSS vaccine showed a 39% reduction in clinical malaria and 29% for severe malaria. And the modeling suggested that there is 1 life saved for every 200 children vaccinated. But there were safety signals identified that wasn't necessarily causal to the vaccine, and there were some other challenges. So WHO asked that there should be some pilots in 3 countries, in Ghana, Kenya, and Malawi. And the pilots were to look at the feasibility of introducing 4 doses of this vaccine that falls outside the normal childhood vaccine schedules. Can we do it? The second one, were those safety signals in the phase 3 trial real or just spurious? And they were meningitis, cerebral malaria, and an excess of female deaths. And the third one was, if you introduce this into routine EPI systems, do you see the same effect? And the answer to all of them was, yes, it's feasible. No, we didn't see those safety signals. And yes, there is the same impact shown, and particularly if you combine it with seasonal chemoprophylaxis for malaria, then the effect and protection goes up as high as 70%. So in October, WHO recommended the malaria vaccine for children at high risk. This is the first time we will have a vaccine. What we have, a big challenge, is vaccine supply challenges. Let's then look at essential immunization in the African region. So what do we know about how we're doing in the African region? And I mentioned that Gavi was established to try and tackle those low figures I showed you in 1980 for all vaccines. Gavi was established started in 2000 and was particularly asked to introduce new vaccines. This is a list of some of the vaccines on the left in the table that Gavi has introduced. And in the graph, you can see the numbers of deaths, the cumulative deaths that have been averted. Most of the Gavi-supported low middle income countries are in the African region. Over 20 years, 9 million deaths. And you can see that pentavalent vaccines, yellow fever vaccines, measles vaccines, having a huge impact on preventing deaths, particularly in childhood. But what about the global coverage with new and underused vaccines? Well, in this graph, you can see that we got up to, for the common vaccines, the diphtheria, tetanus, pertussis, the childhood vaccines you'll have all heard about, we got up to globally about 84 or 83%. But if you look at the measles, the second dose of measles, that's only about 70%. Now, just remember that if we're going to protect particularly children against measles, you've got to get up to about 95% coverage to protect children against outbreaks of measles. So we're nowhere near there. So we've got a problem that we're nowhere near where we should be and where we would want to be. That we also have in those 3 boxes, poor uptake of 3 new important vaccines, the pneumococcal conjugate vaccine, the rotavirus vaccines, less than 50%, and the human papillomavirus vaccine that prevents cervical cancer in the longer term, and is at the moment targeting young girls in school, only sitting at about 13% in 2020. And this is one of the few vaccines that is gender specific at the moment. What we've also saw, which is extremely worrying between 2019 and 2020, is a downturn. So in as much as COVID has caused its own problems, huge problems, we've also seen that routine immunization schedules have been really affected, and we've seen a downturn. And as a result of this, we've already seen significant measles outbreaks in our region, and we anticipate, unless we can get the numbers up, we are going to see more. So finally, putting all this together, what are we talking about now? What is the language that we're using? We went from expanded program of immunization. Now we're talking about chasing the zero-dose children. And why are we saying that, and what does it mean? In this graph, this is looking at the African region. In the blue, you can see the number of infants who are fully immunized. We define that by having the DTP vaccine, the third vaccine, and that's in the dark blue. In the turquoise, it's those who've been partially immunized. But look at the green. These are 8.3 million children in our region who've not had a single vaccine. And this means, and these zero-dose children, as we're calling them, they account for nearly half of all children who die from vaccine-preventable diseases. So they're smaller in number, but very high in mortality. And the African region accounted for nearly 50% worldwide of the zero-dose children. So this is why we're chasing zero-dose children. We want to protect them. They are the most vulnerable in terms of vaccine-preventable diseases. But why else? This is why. If we look at zero-dose children, look at the heading of poverty. If we find those zero-dose children, we're finding that 3 out of every 4 of them are living in houses that are surviving on less than $1.90 a day. They're living below the poverty line. Secondly, if you are a zero-dose child, it's much more likely, more than 50% likely, that your mother didn't receive antenatal care, and 61% of these mothers did not deliver in an institution. And thirdly, zero-dose children are more likely to be found in ethnic groups who are marginalized. So there are many reasons why we are looking to seek and to chase zero-dose children. And let's just think of them. One of them is equity, and this is what we're shouting about with COVID in terms of access. This is really equity again, but looking at all the vaccines. Why do we want to focus on zero-dose children? Because they'll also tell us about missed community. We've committed to the Sustainable Development Goals, and now we've also committed to the Immunization Agenda 2030. And what both of those say is we need to reach every child with immunization. We should leave no one behind, and this is key to universal health coverage. We're saying that this is good value for money. Immunization is the most cost-effective health intervention we have. And post-COVID, countries will need to prioritize health spending once again and look very carefully at what's happened, how have they been affected negatively in terms of immunization programs. If we look at zero-dose children, we will find missed communities, often who suffer multiple deprivations and therefore who are least resilient to vaccine-preventable diseases overall. Finding zero-dose children could be a foundation for primary healthcare, something we wanted to do for many years and we're still struggling to get it right. Immunization services could be a pathfinder for reaching these missed communities and offering those essential primary healthcare services. Remember the antenatal care I mentioned. And finally, health security, so important now with the emergence of new pathogens and new diseases and the lack of surveillance. So health security, missed communities are a potential source, not only of the outbreaks of vaccine-preventable diseases, but also pathogen X outbreaks. If we find those missed communities through zero-dose children, we can engage those communities more fully. So coming back to this, just coming back to where I started in summary, I said, history sure rhymes a lot. So let's just look at what we learned from smallpox, polio, Ebola, malaria, and now to zero-dose children. We've learned a huge amount that we have to do to get successful programs. We need to strengthen disease surveillance in our laboratory networks. We now understand the importance of data for disease surveillance and using that data timeously. We need to set targets. If we look at smallpox and polio, measles, where we're setting target, hepatitis, those targets really do push very hard. We need to improve outbreak response capacity. So the delay in identifying a problem and the outbreak response is is minimized, because the delays are one of the biggest reasons why outbreaks can take hold. Vaccine research and capacity building is critical. We are still complaining in the context of COVID that there is insufficient investment in low middle income countries in the African region into research. And with that, we cannot have manufacturing unless we have a robust set of scientists that can support manufacturing sites. So don't think of manufacturing by itself. We need research capacity. We need stockpiles, particularly for outbreak response. We need strengthened regulatory systems. We need rollout strategies that find those missed communities, that go into conflict zones, that find the missed zero-dose children. We need to build Africa's health workforce, incredibly important as we're saying we want to respond. We want to reach every community, and this is important, and we've learned this with every single one of these examples, through social mobilization and communication, incredibly important. We want to implement accountability frameworks, and finally, we need to reach every child with vaccines. I'd like to thank colleagues who shared data with me, and I'd like to thank you very much for your attention. Thank you.
Thank you very much, Professor Rees, for a great presentation. Conference participants, both online and also physical, we will have a short discussion at the end of all the three presentations, so hold on to your questions. Those online, you can write on our conference page. Our next speaker is Professor John Kiampong from the University of Health and Allied Sciences, Ghana. He will be giving us a presentation entitled COVID-19 in Africa, the Changing Dynamics. May I introduce you to Professor John Kiampong. I hope I'm pronouncing it right. He's the Vice Chancellor, as I mentioned, of the University of Health and Allied Sciences in Ghana. He's a public health physician and an adjunct professor of international health at the Georgetown University in Washington. He trained as a doctor in Ghana and pursued an MSc in public health and a PhD in epidemiology at the London School of Hygiene and Tropical Medicine. His area of research is infectious disease epidemiology. He has over 150 peer-reviewed journal publications and an edited book on NTDs in sub-Saharan Africa. He is a fellow of the Ghana Academy of Arts and Sciences, the Ghana College of Physicians and Surgeons, the Royal Society of Tropical Medicine and Hygiene, and the African Society of Tropical Medicine and Hygiene. Join me in welcoming Professor Kiampong to give his presentation. You have 20 minutes, sir, 20 minutes. I know we went 2 minutes beyond with Helen, but her presentation also was very good, so try to keep to your 20 minutes, and God bless you.
Thank you very much for your kind introduction. After listening to the keynote speaker, I was wondering whether it was worth going through this again, but I will share my thoughts with you. There are similar issues that he has raised in the past, but just to say that my thoughts are all encapsulated in the following slides, and the COVID-19 timelines within the African region is very well documented. From the time that we registered our first cases in February in Africa, and all the loops that we've had to go through till today. This has been properly documented, and I believe it is worth reading for us to see how we have gone through the times as far as COVID-19 is concerned. But suffice it to say that we had our first cases reported in Nigeria and Egypt and South Africa between mid-February and early March. And most of the countries reported cases by the end of March. I mean, Ghana reported our cases in March. Early cases were concentrated among airline travelers returning from regions of the world with very high community transmission. And the initial phase of the epidemic was very heterogeneous. I mean, relatively high case numbers in North Africa and Southern Africa, with fewer cases being reported within the other regions. And this has always been contested, whether it was a true reflection of what was happening or ability to conduct effective surveillance to pick up the cases. As of 31st December 2020, African countries had reported over 2.7 million cases and reported about 65,000 deaths. This accounted for about 3.4% of the global cases that have been reported, and about 3.6% of deaths that have been reported globally as well. In as much as we talk about Africa, I think it is also important to note that a very big chunk of the cases that were reported came from South Africa, Morocco, Tunisia, Egypt, Libya, and Algeria, basically the Northern African countries, and a very few East and Western African countries. Basically, the remaining 46 countries reported between 34 and 55,000 cases each. So again, this has been very well documented in a publication in The Lancet, showing the trends of the COVID pandemic in Africa. As of the beginning of this week, about 250 million cases have been reported worldwide, with about 5 million deaths cumulatively. If you come into the African zone, again, within the same period, we are looking at about 6 million cases that have been confirmed. So all these have also been reported in the 3 waves that the keynote speaker talked about. And therefore, I'll not get into the details of the various waves since it's been discussed previously. But I would like to focus on 3 key issues: what we have done within the African region and what we need to do much better. First of all, key interventions have been the non-pharmaceutical interventions, which are aimed at reducing the spread of the infection. And then also the genomic sequencing that we have done within the African region to monitor the evolution of the virus within the African region. I think it is very important to note that scientists within the African region have done a very significant contribution to this. And then thirdly, to look at the role of vaccines in reducing morbidity and mortality, and hopefully breaking transmission, if at all feasible. So let me take, first of all, the non-pharmaceutical interventions that have been in place. The bottom line has been to limit the spread of the virus. And this is particularly so important when we live in an environment where there is inadequate vaccines and inadequate supplies for almost every thing that we need to do as far as the health system is concerned. So as far as the African region is concerned, for most of sub-Saharan Africa, the non-pharmaceutical interventions has remained the mainstay of fighting the pandemic. So there was a need to encourage people on how to use masks appropriately and more efficiently. It got to a point in time where people were wearing shields, face shields without their nose masks, and there was a need for a lot of education on the use of these non-pharmaceutical interventions, and also how to ensure that there was appropriate social distancing, because the African community is the type that is usually more bonding and more cohesive, and we are a touching society. and therefore trying to understand this whole concept of social distance was a bit of a challenge, and there was a need for us to do a lot of education on this. So you get into some of these market areas and people want to engage, and I mean, it is very difficult socially for our people not to touch. And this has been one of our major challenges as far as the dynamics of the transmission of the virus is concerned in Africa. The use of nose masks, particularly in public places, the use of these masks in public transport. A survey that was done in Ghana that was published showed that over a period of time, only about 20 to 30% of the population were using the masks and using them effectively. Some were wearing the mask on their chin, and how protective is that? What is the utility of wearing the mask on your chin? So the whole issue of engaging, especially in the marketplaces, where people felt that it was very difficult for them to use these as it were, foreign materials that they were not very used to. Compliance has been extremely low, and it is something that we really need to work at. Then the whole issue of washing of hands. Washing of hands, you need potable water. Access to potable water in most parts of Africa has been a big challenge. And in many parts of Africa, there were innovations on how to get about this thing done effectively. And some people actually came up with very interesting devices for hand washing. The use of hand sanitizers, which has caught on now, is something that is, again, very commendable. PPEs for hospitals and health workers may be taken for granted in certain jurisdictions, but in many sub-Saharan African countries, this has been a big challenge, and it put a lot of health workers at risk. And some health workers were very reluctant to be at the forefront of the fight of this pandemic because of the lack of the PPEs. Then risk communication. There were many people who perceived that this was something that was not for them. It was very far away from them because they had not seen people fall off and die from this COVID, and they thought it was a white man's disease. And therefore, the need to communicate the risk was very, very critical. And the president of Ghana is in one of his broadcasts put across a statement which has been seen as very, very effective in reaching out and communicating the message. He said, we know how to bring the economy back to life. What we do not know is how to bring people back to life. We will therefore protect our lives, then our livelihoods. This was seen as very, very important. Unfortunately, when the politics of electioneering came up, all these things went to the dogs. That is another discussion altogether. So as far as we're concerned, non-pharmaceutical interventions are very critical in managing disease outbreaks. We therefore need to ensure local production of these non-pharmaceutical interventions like gloves and gowns and masks, so that we do not over-rely on importation of such things. Health systems and the infrastructure also came into question because we did not have the infrastructure, adequate infrastructure to quarantine and isolate people when necessary. And because our health systems are very fragile and our economies also took a hit, the multiple effect of all these things was not very pleasant in most parts of Africa. I'll talk briefly about the genomic sequencing, which I think the African continent has done pretty well on. From the onset of the pandemic, genomic sequencing has been at the forefront of the fight. In Nigeria, the first genome sequence was released just 3 days after the announcement of the first case. And similar things were done in Ghana and South Africa and many other places. So over a period of time, the African countries contributed their genome into the public database, which has led to the publication of this very, as far as I'm concerned, very, very important paper in Science. Here we describe the genomic epidemiology using the data sets from about almost 9,000 genomes from 33 African countries and 2 overseas territories. Basically, what we find here is that the number of SARS-CoV-2 sequence reflected in the GSAID as at May 5th, 2021. GSAID is a global initiative for sharing all influenza data. And if you look at the map that has been shown here, it tells you which countries put in data there. Again, it's a reflection on capacity of the countries and this development of science in these countries. The details are that we put in together from 38 countries and 2 overseas territories. Overall, this corresponds to approximately 1 sequence per 300 reported cases. And over a third of the sequences were from South Africa. Of course, this is consistent with it being responsible for about half the reported cases in Africa. And if you look at the regression plot of the number of viral sequences versus the number of COVID cases in the various African countries as of May 2021, you see that the countries with over 500 cases of sequences are labeled in this particular graph. And clearly, the overall, the number of sequences correlates very closely with the number of reported cases per country. And the countries and territories with the highest coverage of sequence reflected in here will be Kenya, Mayotte, Nigeria. And although the genomic surveillance started early, after a point in time, the sampling across the whole continent slowed down. And this is something that we need to look at very carefully, because if we are to make progress, we need to ensure that there is consistency in the data collection to inform decision-making for us to be able to understand what is going on. The keynote speaker spoke about this, the various variants that became dominant in the African continent in his graph. So I will not go into the details of this, but clearly Africa had a system of contributing to this. So basically what we're saying here is that half of the African genomes were deposited in the first 10 weeks, suggesting an intensive surveillance in the second wave following the detection of the beta variant from South Africa and the alpha one from the UK and other variants as of May 2021. What we cannot tell now is what is going to happen after this. The data is still being analyzed, and it is our hope that we'll be able to make some sense of being able to predict another wave if it should happen, so that we will be in the position to identify variants of concern as it is done here in this particular graph for the various countries. So through this, we find out that the virus was imported mainly into Africa from January 2020, and it's still an imported infection. Of course, there's been a sustained community transmission going on now, but the key thing for us to note is that the origins of the various variants came mainly from Asia, Europe, and North America. So in summary, as far as the evolution of the dominant variants in Africa is concerned, it is very clear that our contribution to the GSA database allowed us as scientists to be able to look and systematically document what the trend is as far as the various dominant variants are in the African continent. So we in Africa need to continue to make investments in this, because it is only then that we'll be able to identify the variants of concern or variants of interest to help us in probably developing new responses and vaccines as we move along the line. Talking about vaccines, again, the issues that I was planning to talk about has also been highlighted by the first speaker, the keynote speaker. But let me say that way back in 2020, the Economist Intelligence Unit reported that more than 85 poor countries will not have access to widespread COVID vaccines before 2023. And they predicted that most of the countries in Africa and Southeast Asia will get their vaccines by late 2022 or 2023. This was based on the work that they had done, looking at how vaccine nationalism was jeopardizing the whole vaccine distribution system. Indeed, it was at a point in time that the richest countries had already bought 80% of the Pfizer vaccine. So if you do not have the money and you are going to credit the vaccine, then where are you headed? So I think it is about time for us to look at vaccine acquisition as a public good. And as Helen talked about in the previous talk, vaccines should be seen as a public good because it's shown and demonstrated very high effectiveness in taking care of many of infections of public health concern. So as we speak now, about 7.5 billion doses of the COVID vaccine has already been administered. Over 52% of the world's population have received at least one dose of COVID vaccine. Unfortunately, only 4.5% of people in low and middle income countries have received at least one dose. I checked with my program manager for immunizations a few minutes ago. Ghana is doing around 13.5% for at least one dose and 4.2% for fully immunized. If you look at this graph, it tells you how things are going as at the end of last week. I think South Africa appears to be doing quite well relatively, but it's at the bottom of this table where they have about 27% receiving at least one dose. So it tells you very clearly that we cannot continue on this pathway if we really think that vaccines are going to be the solution to the problems that we have currently. And this, again, this graph was shown by the keynote speaker. This tells you the COVID vaccines administered per 100 population globally. And I mean, it is such a pity looking at what is going on in Africa. There is a big hole, but we live in a global community. We live in a global community, and we need to ensure that we take care of one another. Otherwise, like the fire tenders, that story that was shown at the end of the last presentation, we all over the world could be engulfed in this problem. So now you hear developing countries demanding equal access, and then WHO coming in to talk about equitable distribution of the vaccines. Yes, this is all good talk. And again, we heard about COVAX and what COVAX has been able to do so far. I guess the message is that no country is an island. A collective approach to COVID-19 vaccines is the only way to go. And even if we look onto the deprived continent of Africa, again, the disparities are very clear. There are some countries that are doing less than 1%. There are other countries that are doing over 20%. So how do we ensure equity? But for me, more importantly, as a scientific community, what is the role of African scientists in vaccine development? Should we continue to sit aloof? How much investment have we done in vaccine development? Even when we do not have the capacity to develop the vaccines, how have we participated in clinical trials? These are all very important questions because, in my humble opinion, we cannot sit back and do nothing and then at the end of the day begin to demand a fair share of what has been developed by some group of people. I think we need to take a center stage and play an active role because we have the capacity. We have the scientists, we have young scientists who are up and coming, who can take center stage in doing this with the appropriate advocacy from our politicians to get the necessary resources to support our vaccine development programs and to encourage participation in clinical trials so that we can have access to these vaccines. The issue of vaccine hesitancy is another story altogether. We need to educate our communities and get our people on board as far as all these issues are concerned. So to end, I would say that as far as the journey of COVID-19 in Africa is concerned, non-pharmaceutical interventions have played a very key role and will continue to remain a very key intervention for most of Africa until we can have access to vaccines. And therefore, we need to take the non-pharmaceutical interventions extremely serious. Our genomic sequence to track and monitor the evolution of the virus is again something that is very commendable, and we should continue to do so, invest a lot more so that we will be able to make predictions of what could be happening in the future. Vaccines to reduce morbidity and mortality hopefully will break transmission, and we should do all that we can to ensure that we have access to these vaccines. And my main message in this whole communication is to say that Africa needs to take a more proactive role, and we should not just sit back. We should be more proactive as far as the science is concerned, because we have the capacity. I thank you all for your attention.
Can give a better clap to Professor John Kiampong. Indeed, this is the time for Africa to arise in the scientific community, even as we deal with this. Our last speaker this afternoon is Professor Supriya Mehta. Dr. Mehta is a professor of epidemiology and interim associate dean of the global health at the University of Illinois, Chicago School of Public Health in the United States. She completed her doctorate in infectious disease epidemiology at the Johns Hopkins Bloomberg School of Public Health, followed by a CDC-supported postdoc fellowship in sexually transmitted infection prevention. She has worked in Kenya since 2007 as a co-investigator on the randomized controlled trial of male circumcision to reduce HIV/AIDS incidences. She has also worked as a PI of a longitudinal study of heterosexual couples to identify under what conditions the penile microbiome leads to reproductive tract infections in female sex partners, and also as a PI of a cohort estimating the effects of menstrual cups on the vaginal microbiome and sexually transmitted infections among Kenyan schoolgirls. Dr. Mehta is committed to research that leads to tangible benefits in sexual and reproductive health. Professor Mehta will give us her presentation entitled Effects of COVID-19 Pandemic on Sexual and Reproductive Health of Adolescent Girls and Young Women. How can we mitigate and prevent unintended harms? Examples from Kenya. Ladies and gentlemen, Professor Mehta to speak to us.
Thank you so much for the kind introduction, and also to Arua and Professor Ayiti and the conference organizers, as well as University of Pretoria, and to everyone in attendance today for taking the time to be here and making this an important part of your day. So I'll be shifting a bit away from not the direct effects of COVID, but the indirect effects of that, in particular in relation to how that has shifted the dynamics of sexual and reproductive health. So I have no conflicts to declare. So we've all seen the overall pandemic dynamics for Africa, and here showing 4 countries with Kenya in the top left corner. Mostly they're the same with 3 waves, although Kenya did have 4 waves, and the reasons for that are unclear. However, the case rate is similar to that in Ethiopia and Uganda and Nigeria, and of course, South Africa with the highest rate. The vaccination rates remain low, as they do in most of the countries in Africa, as we've been hearing repeatedly about the vaccine shortages and the refusal or inability of the wealthier countries to share vaccines. So what we'll be looking at is how the pandemic and the mitigation measures that have been undertaken to prevent illness and death have had downstream effects or unintended effects on sexual and reproductive health, particularly for adolescent girls. So with many disruptions to population level disruptions, not just epidemics, but also natural disasters and conflict, we see that the inequities in our societies are exacerbated, and that in particular, women and girls are disproportionately impacted. Looking at these figures from the World Bank Group, we see that during COVID for Kenya, from February to the May through June period when there was lockdown, that the income in figure 7 was a much greater drop for women than for men. We also see that in female-headed households compared to male-headed households, women were more likely to miss meals, they were more likely to have insufficient food, and children were more likely to have gone to bed hungry. And this is driven in large part, as described in a report by McKinsey, by the gendered differences in the labor markets and economy and participation in domestic work. However, that's only about 25% of the explanation for why women and girls are disproportionately impacted, these economic things. The other 75% is attributed to gender inequality and entrenched barriers that women and girls face. So these socioeconomic disparities and exacerbations of poverty and disparities also intersect with interpersonal violence, domestic violence. So in a multi-country study that was done in sub-Saharan Africa, they found a 92% increase in interpersonal violence as reported from the January through June of 2020 compared to January through December of 2019. And this figure in the bottom center is showing results from Rosa Pandi from Uganda, who presented at International AIDS Society this year, showing that the pre-COVID to COVID period rape case increases as well as the teenage pregnancies. And a lot of this is driven by the economic stressors, the lack of access to healthcare services, the disruptions in general healthcare provision. But this, of course, is not restricted to Africa. This is a global concern of this disproportionate impact on women and girls. And this figure in the bottom right is showing Google searches for domestic violence for 4 countries with the highest rates of COVID. So India, the United States, Brazil, and Russia. And what we see is that during the immediate lockdown period that most countries enacted, that these searches increased dramatically. And this is, again, due to the gender inequality, these existing barriers and structures for women and girls. So how do we have an example of this from Kenya? So there's an intersection of these conflicts with sexual and reproductive health for women and girls. And prior to the COVID-19 pandemic, we had been studying menstrual cups and community health for secondary school girls in rural Kenya. We began in 2018, nested in a clinical trial, a controlled trial. And of course, as you can see from this timeline here, that our end line fell right within the onset of COVID. And so of course the schools were closed. And so we missed our end line. However, we have continued with the support of NIH and KEMRI, welcome the UK funders to follow this cohort. So I'll be talking to you about the dynamics of the change in sexual and reproductive health from prior to the COVID period to during the COVID period. So just a little background on menstrual cups and why they would be related to sexual and reproductive health. So menstrual cups here shown to the right, this is a silicone-based device that collects blood. It's inserted inside the vaginal vault and the blood is collected there. And so there is a protective effect in that the vaginal pH and the microflora do not change as much as when there is blood in the vaginal vault. And in a pilot randomized trial of over 640 girls, aged 14 to 16 in Kenya, Dr. Phillips Howard and her colleagues found that girls who were randomized to menstrual cups as compared to standard wash or pads had a 35% reduction in bacterial vaginosis and over a 50% reduction in sexually transmitted infections. They're now scaling this to 4,400 girls in rural Western Kenya to look at the impact on HIV, HSV2, and school retention associated with menstrual cups. So this gives us the opportunity to look more deeply into the mechanisms by which menstrual cups could protect against sexual health. So I'll give a little bit of the details of that so that you understand how we are able to measure the impacts of COVID-19 in this cohort over time. So this study that I'm presenting on is called CACHE, Cups in Community Health. We call it CACHE, and it's initially designed to look at the impact of menstrual cups on the vaginal microbiome, and then subsequently bacterial vaginosis and sexually transmitted infections. We're also looking at the impact on sexual behavioral risk. In a household survey of over 4,000 women and girls in rural Western Kenya, of course, prior to the pandemic, about 40% of the women and girls were using traditional objects. So cloth or grass or paper, socks, rags, etc. And this in previous studies has been shown to be associated with increased risk of reproductive tract infections. But at the same time, because so many girls miss school due to menses for the stigma that's associated with that, 10% of girls aged 15 were engaging in transactional sex to purchase or to receive menstrual pads. And so menstrual cups could then relieve the pressure of A, not being able to go to school with inadequate management of menses, and B, having to have other coping strategies to obtain menstrual pads. So this could serve as a multi-purpose tool. And so could it lead to, of course, menstrual hygiene management that is safe and cost-effective with a reduced environmental impact? Yes, so we have green check marks for that. So menstrual cups last for up to 10 years, and they have very low risk of toxic shock syndrome. But if they can also help girls stay in school and reduce HIV and STIs, then this helps decision makers on how to scale menstrual health and menstrual hygiene programs, but also for women and girls when they choose their menstrual hygiene management and programs and donors as well. So the trial from Dr. Phillips and colleagues has 4,400 girls, and they have 4 arms. So a menstrual cup arm, a menstrual cup plus cash transfer arm, a cash transfer arm only, and then a standard arm, which is wash. And so we have enrolled 20% of the girls in the cups arm and 20% in the wash arm, which is standard wash. The study is a cluster randomized controlled trial. So we have 3 schools that are from the intervention arm and 3 from the control arm. So we have been collecting detailed information every 6 months from the participants as listed here. So an extensive survey that's collected by the girls on a tablet. It is self-collected with socio-demographics, sexual activity, information about their partners and practices, and of course their menstrual hygiene practices. And in terms of their health, we are measuring BV, chlamydia, gonorrhea, trichomoniasis, so a number of STIs, and of course microbiome sequencing so that we can understand the effectiveness or efficacy of the vaginal cups. So the study, as I said, it takes place in Kenya. We are in Western Kenya, about 80 to 100 kilometers from Kisumu. So Siaya is the rural county that we're working in, and the locations are shown in the upright. So we work with the government, Kenya Medical Research Institute, or KEMRI, the Center for Global Health Research, as well as a non-governmental organization called Nyanza Reproductive Health Society. And the images here show pictures from Nyanza Reproductive Health Society, who provide clinical services as well as a lab where the specimens are tested and processed, and KEMRI that does the logistics support, policy, and regulatory support. So prior to conducting this study, there was quite a bit of community sensitization and mapping, ensuring that wash standards were met for schools so that the latrines were up to date and that there was soap and water available. Schools were consented, as were parents. So once all of the preparatory work had been done, girls were also assented in the field after the study had been explained to them on several occasions. So we set up private areas with nurses and research assistants coming to the schools. So this was a school-based study, and the schools very generously gave us time and space in their students' days to provide the health information and to do the testing for these studies. So girls were given a health talk at the beginning of a session so that they were given information about how to prevent STIs, about treatment for STIs, symptoms, and what the microbiome is as well. And then here showing our Liz, the trial coordinator, and Clara and Maureen, who are some nurses, who undertook the study procedures. We had a lab assistant in the field who did the quality control. This is Hilda here doing QC on the specimens as they're received, and then they were processed in the lab when they returned. So the girls were median age 17, and 97% of them were using pads, but also 42% were using traditional cloths to manage their menses. And in terms of characterizing the population, 40% of them, the main source of electricity or the main source of light was kerosene. About 60% relied on surface water, and 45% had traditional pit latrine. So it's a quite rural and impoverished population that we worked with. 30% of girls reported that they had ever had sex or been forced to have sex, and the distribution of whether that was forced sex or willing sex is shown in the pie chart. So just under half of girls said that they had only had sex willingly, and about 25 to 30% had been forced to have sex and had sex willingly, and about 25% who had been forced to have sex. And of the girls who had ever been sexually active, only 9% were using hormonal contraception. The prevalence of sexually transmitted infections and bacterial vaginosis were very high. About 10% of girls had any sexually transmitted infection and 11% with BV. And so overall, the infection prevalence rate was about 17.4%. These figures at the bottom show that the prevalence of both bacterial vaginosis and STIs increased with age. So, and that is in keeping with sexual activity occurring increasingly as the girls age. These are the results of the amplicon sequencing showing the distribution of the community state types, and then on the y-axis, the relative abundance. So this x-axis shows 1, 2, 3, 4A, 4B, 4C, and 5. Those are the community state types. And then these colors represent the dominant bacteria in the vaginal microbiome. So we see that in community state type 1, the dominant taxa is Lactobacillus crispatus, which is considered to be dominant. And so this was the most common vaginal microbiome type, which is different from many other studies that have been done showing high prevalence of non-optimal or CST3 in sub-Saharan African communities. And so what we find is that because a lot of these girls were not sexually active, they had an optimal vaginal microbiome community. And the next most common was Lactobacillus inners, followed by non-optimal composition, which was 4A, 4B, and 4C. And then 2 and 5 community state types were Jensenii and Gasseri, which were outliers. So what does this mean in terms of outcomes, and why does it matter that we've characterized this? So when we look at the girls' risks and outcomes in relation to these community state types. So again, the most common was the optimal community state type of CST1. But when we look at CST3 and 4, which are the lactobacillus inners in 3 and non-optimal in 4, we see that there's high prevalence of girls who have been sexually active. And in CST4, more than half the girls had BV prevalence of 52%, so more than half had BV. And the prevalence of STIs was 24%, with 60% of the girls in CST4 having BV or an STI. So we see that this changing vaginal microbiome composition is also associated with different risk of BV and STIs. And then in terms of menstrual hygiene management, what we're most interested in here is in this multinomial adjusted model that the girls who used cloth during their last period, so again, that was about 40% of girls, were adjusting for age, household amenities as a socioeconomic measure, sexual activity, and body mass index, were more likely to have CST3 or CST4 compared to the optimal CST1. And this is in keeping with the literature, which has used non-molecular approaches to show that cloth use is associated with BV and reproductive tract infections. So now that we've characterized the cohort in microbiome as well as STIs and behavioral practices, how has COVID-19 affected these adolescent girls and young women? So the figure above shows the timeline of how the study was supposed to go and then what happened. And so what happened was we missed our end-line visit at the 24 months. And so we resumed in October and November of 2020. So Kenya remained closed until July. And then once it reopened in June, we submitted IRB to shift to the field. Now, of course, the schools remained closed at this time. So at both the 30-month visit and at some of the 36-month visit. And so we worked with the local churches, because churches were allowed to remain open, to be able to provide services to the girls. And so these figures show one of the churches where we worked with and how we maintained social distancing, mask wearing, hand hygiene. And the churches themselves, this figure on the right is showing at one of the churches that a number of signs that they had posted: know your temperature, sit here and maintain social distancing, and to wear your mask. And so this was all done very collaboratively in partnership with churches. So looking at the preliminary impacts of COVID-19. So in the prior period, we did see some increases in BV and STIs from baseline to 18 months. But, and STIs, I should say, were measured annually. And the prevalence in BV did not increase at the 18-month visit. However, once we resumed at the 30-month visit during COVID, we saw about a 40% increase in BV and another 30% increase in STIs. Looking at the center chart where we see pregnancy, current pregnancy, there's a tremendous jump in pregnancies. And this is, of course, because girls were out of school. Many of them migrated, got married, and or got jobs, and of course, were not in school to kind of prevent or delay or postpone these situations. And so pregnancies jumped from we usually had 2 to 3 pregnancies at each study point prior to that. And then we had 19 pregnancies at the 30-month visit, and then an additional 12 at the 36-month visit. Below that, we see the number of abortions. Of course, abortion remains illegal and widely underreported. But again, we see a jump in the number of girls reporting an abortion at the 30-month visit, and that's declined, but is still elevated at the 36-month visit. There's also an interaction of mental health and sexual health. What we see looking over time, so we've measured anxiety over time and depressive symptoms using the personal health questionnaire. And so here I've stratified that by BV status to show the interaction of mental health with sexual health. So in this figure on the left, we see that anxiety declined for girls who did not have BV. So they were less likely to be sexually active. But we see that for girls who had BV, their anxiety remained at 20%, basically from baseline to 30 months. Their anxiety did not decline over time. And on the figure in the figure on the right, we see that depressive symptoms, so that was about 25% of the population for girls who had BV, meaning they were sexually active and at risk for STIs. And that increased slightly from 12 months to 30 months, whereas for the girls who remained BV negative, it was lower and decreased over time. So those with depression and anxiety are more likely to have BV, and those with BV are more likely to have depression and anxiety. And in a moment, we'll look at what are the possible explanations for that. Looking at the socioeconomic impacts, about 70% of girls reported increased food insecurity at the 30 and 36-month visits. And this is in large part because many of them had been receiving meals at school. And so then there's less food available, but also 89% reported that their family's income had declined during COVID. 30% of girls reported difficulty accessing water at the 30-month visit. Again, often clean water was accessible in schools, but then of course, when schools were closed, that may have been less accessible. And again, 60%, the primary source of water was surface water. And so there's some variability with the season, whether it's the rainy short rains or the dry season or the long rains. So this middle figure is highlighting the engagement in transactional sex by BV status. So overall, transactional sex declined from about 7 or 8% at baseline to about 10% at baseline to about 7 or 8% at 12 months, which is what we would hope to see with this intervention where we're providing menstrual cups and other testing and treatment and counseling to prevent STIs. But what we see is that for girls who are sexually active, who have BV, that there's a huge increase in transactional sex. So overall transactional sex increased to about 14% at 30-month visit. And this was much higher amongst girls with BV, using that as an indicator of STI risk, because again, we missed our 24-month visit of the STIs. So this last figure on the right is showing the distribution of the COVID impact score. So we implemented some validated survey tools that have been available through NIH to look at COVID severity and stress. And so looking at the girls of how much anxiety and stress they felt, how worried were they about getting COVID, transmitting it to someone they know, about getting sick, about the economic stresses, the social isolation, the inability to move about. So there were a number of questions, about 10 or 12 questions on this survey. And what we found at the 30-month visit, which is the top figure, was very high. About 30% of the girls had the highest score on all of the items. And then we can see at the 36-month visit, which is below that, there is some shift to the left. So some of that acute stress has decreased, but still about 20% of girls are at the highest level of stress in relation to COVID. So how do all these pieces fit together? So this is a structural equation modeling result, and I'll walk you through it because it's a little bit complicated when you just look at all the lines and numbers. So we started with, COVID being the main factor, and everything else is downstream of that. And so we looked at depressive symptoms. We looked at safety in the home. So I should also say we had a lot of measures on domestic violence and interpersonal violence. And one of those that I'm keeping here is feeling less safe in the home. We used difficulty accessing water as our socioeconomic measure because such a high percentage, 70%, had food insecurity and 89% with decreased income, whereas there was a bit more variability for water access. And so what we found is that those girls with increased stress, with higher stress, had more difficulty accessing water and felt less safe at home. They also were more likely to have depressive symptoms, although this didn't reach the P less than 0.05 level. So these are pretty strong correlation coefficients for COVID-related stress and safety in the home and difficulty accessing water. And then what we also see with this socioeconomic factor is that girls who had more difficulty accessing water were more likely to engage in transactional sex and more likely to have boyfriends. Similarly, for girls who said they felt less safe at home, they were more likely to engage in transactional sex and more likely to have boyfriends. And these asterisks and stars represent the different levels of statistical significance. And then unsurprisingly, the proximal variable is sexual activity, meaning transactional sex or boyfriends. And the route of transmission was equal between boyfriends and transactional sex, but these were driven by COVID-related economic pressures and COVID-related stress factors and COVID-related safety in the home. So we have an imperative to monitor the long-term impacts One of the things that Dr. Coupe had brought up was that it isn't just COVID. There are many other things happening at the same time. And so the gains in sexual and reproductive health that have been made over the past 30 years are at risk of being reversed or stalling. And we need to identify ways to not just mitigate COVID, but to reverse COVID and then prevent subsequent disruptions that will happen from the continuing epidemics, natural disasters, and conflict that happens. And so what we will be doing is monitoring these girls for an additional 2 years. So we'll be going through 66 months. And of course, when the schools are now open, and when we submitted the grant, we were hopeful and we called it a post-COVID time period, but obviously we're not in the post-COVID period. And based on vaccine availability, it is unlikely that we'll be in a post-COVID period until after 2023. And so the mitigation and the risks will remain in place at least through next year. And we remain in a COVID period. And so what we'll be doing is looking at quantifying the economic, social, and behavioral impacts of COVID-19. We'll have the trajectory from pre-COVID to post-COVID to be able to compare those. And really looking at these stressors on long-term risks for HIV, STIs, as well as pregnancy. And then to determine the extent to which BV and STIs are biologically mediated by stress. So really looking at all of these factors together, because the concern is that these impacts, so while we have focused on the immediate threat of COVID, because it is life-saving, it has been at the expense of many other non-COVID health conditions. And sexual and reproductive health in particular, it cannot be ignored as non-life-saving. At this particular point in these girls' lives, to acquire HIV, to have unplanned or unwanted pregnancy, to have STIs, early marriage, these things have lifelong consequences that affect not only quality of life and health outcomes and maternal and child mortality and morbidity, but there's increased lifelong risk on a population level. And so it's important that we have these measuring the data for this to be able to make some decisions. And then how can we use this once we've measured this data, once we've quantified this, how do we use this to then mitigate and reverse these COVID-19 impacts? And so of course we call this data to action, and we need to be able to put this in place right away, not just to mitigate COVID-19, but to reverse these detrimental impacts. So we need to accelerate the gains that we were previously experiencing so that fall off that we've seen, not just in gains in immunization, gains in HIV, gains in sexual and reproductive health, these drop-offs that we've seen, we can't allow those trajectories and just say, oh, it'll return to normal over time, but we need to reverse those declines due to COVID so that we can get back on track. And so some examples here are some of what are the concrete things that we can do? So we can use this data to redirect or to direct existing support programs to those who are in greatest need. So those who are at greatest risk for mental health impairment or sexual and reproductive health risk, and to retailer them to respond to these increased risks of domestic violence or economic pressures. What we also need to do is to develop, strengthen, and hasten non-COVID surveillance. So miraculously, pretty strong COVID surveillance has been put in place where other surveillance systems may have been lagging or underfunded or suffering. And so what we would hope to do and what we would like to do is translate some of the infrastructure and knowledge and skills related to COVID surveillance and transfer that to the non-COVID related conditions. So whether that's sexually transmitted infections or other conditions of concern for lifelong health. We also need to reinforce communication campaigns. So there's limited data that's available in the literature on the intersection of COVID-19 and impacts on adolescents in terms of
hear me,
sexual
Professor
risk
Mehta?
behaviors.
Professor
Yep,
Mehta,
sorry,
can you hear me?
Yes, I can hear you.
Yeah, summarize if you don't mind. Thank you very much.
No, this is the last slide. But so one of the things is just ensuring that that teenagers know how to access care and to do it accurately. One study found that up to 50% of teenagers were not accessing care during COVID because they didn't know that they could or they didn't know how. I think donors have a big focus on technology right now for expanding and improving access, but technology cannot deliver food and water or housing and domestic safety, nor can it deliver testing or antenatal care services. And that the efficacy of mental health counseling via technology is not well established, especially for teenagers and for areas with low technology penetration. Other options are to have targeted cash transfer to mitigate negative coping strategies. And there have been stimulus in South Africa had a stimulus, the US had one, many countries have used stimulus, but targeted cash transfer can help in particular. And then of course, engaging men and boys, but also I finished with balanced consideration of risks. So schools were closed for a very long period of time. And going forward, if we can quantify this, what are the long-term outcomes of school closure versus keeping schools open and the benefits that that would have against the risks of the threat that are at hand. And just to finish, this is a mural from one of the buildings in Kisumu, targeting children, that you have the right to be protected from any harm during COVID-19. So that's it. Just thank you to our funders and to Kenya Medical Research Center and NRHS and my co-investigators.
Thank you very much, Professor Meta, for now bringing the discussion on COVID-19 to individual lives, to communities, and then challenging us on the way forward. Participants, we had said that we were going to have a small discussion time, but because of time limitation, I will request that each one of you who has a question to put it online so that we can forward it to the presenters, and then we can assure you that you will have a feedback in terms of the questions that you have asked or any intervention. So I think from where I sit, we've had a very fruitful discussion. On all matters, I will not try to summarize everything, but basically looking at how, as Africa, we have a very serious pandemic, health pandemic, that has interrupted our lives in very significant ways. Nothing was left the same way after the 2020 entry of COVID-19. And so the way we responded as scientists and as communities has been elaborated by Professor Rees, Professor Hiampong, and Professor Meta has brought in the issue of reproductive health in the mothers, maybe a little bit early mothers of the continent. And therefore, there's so much for us to do as a scientific community going forward to ensure that Africa plays its role in the global dynamics that disproportionately affect Africa, and also to encourage us that we are up to the task as the scientists, as the stakeholders, as the mothers, and I'm happy that even the fathers of the nations of Africa are coming to fore. So as much as we have looked at the impact on the mothers of the nations, because they have said, if you want to tell me how well you are, show me your mothers. And so on that note, I think we will adjourn and go to the first parallel sessions, and maybe I'll ask Lindy Ziwe to come and give us the directions. But on behalf of the entire organizers, I want to thank Professor Rees most sincerely for giving us insights into what we normally call routine, but they are no longer routine immunizations in Africa, and how then going forward beyond COVID-19, how are we to do as Africa? We also looked at the changing dynamics from Professor Hiampong, and really to raise an alarm that this thing is changing so fast, and how can we then prepare ourselves as Africa to intervene in the interim and also in the long term. And I said lastly, how COVID-19 pandemic has actually impacted very negatively on the sexual and reproductive health of the adolescent girls and young women. And now going forward, we are going to look at other sustainable methods of also incorporating other community players going forward, So I want to thank you most sincerely for your attention and to wish you very fruitful discussions, even as you delve further during the first parallel sessions that are coming now for about half an hour, and then we shall go for lunch, unless I give back to the organizers. But I want to thank you for your attention and allow me to moderate this session.
Thank you very much, Professor Hutchinson. It's my understanding that the breakout rooms are all behind you. So if you can choose which breakout room you want to go to, we do have one and a half. So lunch, I think it's still at 1:30, so you finish and then we'll break for lunch. So the breakout sessions are right behind you. You are invited to join the session that you are interested in. Pandemic in poor and rural communities, chaired by Professor Tali Palmer. And then the 2.3, which is on unemployment and its impact, chaired by Murray Librant. Sorry? Yes, page 19 of the program, yes. So all the 5 breakout sessions, rooms are behind you. And they are properly labeled. Good afternoon, ladies and gentlemen, and welcome back. We are now going to have our second keynote address to be delivered by two professors from University of Cape Town. They intend to share the presentation. So we have Professor Linda Gale-Becker, who is a professor of medicine and the chief operating officer of the Desmond Tutu HIV Foundation. He's also the director of the Desmond Tutu HIV Center at the University of Cape Town. And then we have Professor John Eleojo Ataguba. He's an economist at the School of Public Health and Family Medicine at the University of Cape Town. And they'll be speaking to us on counting the cost, global public health challenges in Africa. So let me hand over now to the team, Linda Gale-Becker and John Eleojo Ataguba.
So much indeed, and it is our great pleasure. Thank you to the program chair and the organization for this opportunity. John and I are doing a duet, and John is going to start the duet. So I'm very pleased to hand over to John, and I'll move the slides forward for him.
Many thanks, Linda Gale, and good afternoon, colleagues, depending on where you are, good day. We'll be talking about the costs to the economy as well as society when we deal with public health challenges in Africa. We'll try to anchor these within the context of pandemics and epidemics. I will take on, as an economist, we like dealing with the economy, so I will touch on the impact on the economy or the cost to the economy, and my colleague Linda Gale will take us through the societal impact. Now, within Africa, there are so many public health challenges that we face, many of them. But I want to highlight one that has come up over and over again today, is the diminishing global solidarity. We seem to be falling apart. We seem to be losing it. It's something very important as countries want to unite and grow and make sure we deal with public health challenges. We really need global solidarity, and especially pandemics that cut across countries. And there is this rising challenge with burden of disease and the changing pattern of the burden of disease on the continent and globally that have impact for us. And there are financing issues as well, which I'll touch on, and the broader economic cost of diseases. Thank you. Next. In terms of, I'm not sure whether you can see that, but we'll try to talk about it. In terms of burden of disease, as at 1990, you would see that many countries, especially we try to show you countries that form part of ARUA, and of course the sub-Saharan African column is there. You would notice clearly that non-communicable diseases were not that prominent, apart from a country like South Africa as of 1990. And you could see the pattern of the disease burden that these countries face. And by 2005, which is the next slide, you would see that the pattern has kind of changed, with South Africa having a higher burden of from communicable diseases, including maternal and neonatal issues. But injuries continue to remain number 3. Again, you would see at the bottom that the pattern is also changing slightly with countries heavily with the onset of HIV/AIDS, that countries now started bearing a higher burden of HIV/AIDS. And you would see countries like Uganda, Tanzania, and South Africa, HIV/AIDS became number 1, leading cause of death on the continent. Then by 2019, the picture is pretty much similar to what we saw in 2008 and 5. But now more countries are joining in terms of burden of HIV/AIDS. And previously, the respiratory infections still continue to be a major killer on the continent. And Rwanda, again, suddenly jumped into a country where non-communicable diseases kind of took over. as a leading cause of death, in addition to countries like Senegal. Sorry, yeah, Senegal. Next, please. Great. You will see, let's come into health financing, because it's a very big challenge that we face on the continent. We don't have enough resources. The share of government in financing health services is really very low in Africa compared to many other countries, especially upper and high income countries. In sub-Saharan Africa, for example, you would see that government expenditure as a share of how much is spent on health in the country sits at about a third compared to 60-something% for high-income countries, or close to 60% for upper middle income countries. Now, this is an indication of a big challenge. Reason being that health is something that we see as a very important component of government's own duty. And if government is not able to put in enough resources into financing health services, it's a big challenge that comes out in terms of government's preparedness to deal with pandemics or any emergent disease that can arise at any point in time. Next. Again, the same picture we see with out-of-pocket payment, the flip side. Countries in sub-Saharan Africa depend heavily on people financing services out of their pocket, which is a big challenge. In countries like Nigeria, for example, you could have up to close to 70% of total health financing coming from out-of-pocket expenditures, which is very problematic. And if you compare that with high-income countries, you see that the share is something very, very small, lower than 14%. Now, we've seen consistently that countries where this share is less than 20% are countries that can provide financial protection in the form of avoiding impoverishment. But having a share that is more than 20% predisposes people within the country to high financial costs when they seek health services. Next. Again, another challenge related to health financing is the fact that overall, whether you look at public or private, how much do we put into financing health services? Sub-Saharan Africa is very, very low, sitting at about 5% of GDP compared to 12 or 13% for high income countries. Now, this basically tells us the share, the value we put into health when we look at the entire economy. Next. So summarily, you would know that many countries in Africa lack universal health coverage because overall spending on health services, like we've just seen, is really small compared to high income countries. And the reason why it's very troubling is the fact that we sit with a very high burden of disease compared to high income countries. Though the disease pattern might be different, but the overall burden is high on the continent. And we've consistently seen that hospitals and curative services take a larger chunk of monies that go through the health sector, accounting for close to 70% of health spending, with very little priority given to primary health care. But we know that primary healthcare services are utilized mainly by the poorer segment of the population. And it really accounts for, in many countries, close to 70 to 80% of health service utilization in terms of volume, but not necessarily cost. And we know also that dealing with diseases at the primary care level really saves a lot of money if you have to move from lower level to higher levels. Next, and to finish off that, we know also that as you leave the primary healthcare level to higher levels, you lose the poor because poorer people are unable to use referral hospitals compared to the very, very rich. Now let's look at what we're dealing with, COVID-19 pandemic on the continent. In terms of causes of death, you would see that the burden next is high when we look at countries within Southern Africa. Next. Compared to countries in Central Africa. The very, very high bars there you see are bars that come from Southern African countries in terms of number of cases, in terms of number of tests done, as well as number of deaths. They're predominantly higher in the Southern Africa region compared to Central Africa, which is the least. So we clearly see now that the need for, we talked about health financing and the need to pay close attention to how health services are being financed is really, really critical if we need to deal with the challenges we face. Next. And we know from what we've been seeing, this has been shown earlier, that the picture in terms of distribution of COVID vaccinations has not been good, has not favored Africa, unfortunately. If you take a look at that chart, you would see that Africa is predominantly light as at April 2021. And by August 2021, next slide, you will see that the picture has not changed for the better for Africa, even though it's changed significantly for the global north. And even Asia is again becoming pretty much better, and Latin America as well. But Africa has remained pretty much where it was since April. Next. So what we see here is that the contemporary, a very important challenge that we face now is how to achieve vaccine equity. Next. And to achieve vaccine equity, we need to ramp up the vaccination rates in Africa. Given that we need to use vaccines as a way to protect people from diseases. Only very few countries in Africa, like Seychelles, Mauritius, have been able to attain very high coverage of vaccines. Now, if we need to do that, we want to also ensure that African countries are able to manufacture vaccines. But unfortunately, only 1% of vaccines, not just for COVID or even Ebola, are really produced on the continent. All the vaccines, of all vaccines used on the continent, only 1% are produced locally. And you could see the hub of production. Of course, it's not to maximum capacity. Next. And we definitely know that to do that, we need to address the vaccine inequity, even in the short term. That is very, very critical. So what have we seen in terms of the economic impact of COVID-19 when we look at the continent, Africa? We've seen that by as at 2020, there was significant reduction in the GDP. GDP is the gross domestic product of Africa put together, shrinking by about 2.1%, even though it's estimated to rise by about 3.2% in 2021. We are yet unsure of that because of many things we've seen, even in terms of access to vaccines, and provided we're able to keep debt rates low and also boost investor confidence and many other things like transport opening up and people were able to get into tourism. The tourism sector was really hit. Countries that are dependent on tourism witnessed about 11% reduction in economic growth. Whilst it is very minimal in oil-rich countries, Nigeria, for example, with about just 1.5% decline in economic growth. And debt burden increased, more than close to 40 million more Africans, new poor, were added purely because of COVID-19. And this is roughly slightly higher than the current population of Ghana. So you can imagine a whole country of Ghana in Africa becoming poor purely because of COVID. And the cost of eliminating COVID, poverty caused by COVID, is estimated at close to 8, depending on what scenario is looked at, can range between 4 to 8 billion between 2020 and 2021. Next, please. Great, so let's come home to South Africa. A recent study in South Africa showed clearly, depending on what scenario, whether the impact is mild or the impact of COVID is severe, that poverty COVID caused an increase in poverty headcounts, as well as the depth and severity of poverty. But interestingly, inequality reduced, which is very striking. The reductions in inequality were associated with the fact that the rich tend to have capital income compared to the poor who are dependent on government transfers. And transfers were really useful means to alleviate sufferings from COVID-19. Next. Great. And also, let's borrow from Ebola. I would highlight this quickly. Result or studies done by Centers for Disease Control and Prevention, the US centers, shows that Ebola itself had a significant impact on the economy. This has been highlighted earlier today, with people who have lost jobs next, people who, in terms of the health sector, people who've died, and also the debilitating effect from disease. And also the fact that within the health sector, we lost healthcare workers, which makes a lot. And there's also impact on children losing their caregivers and mothers and fathers. Next. So with that, I want to hand over to Linda Gale, and thank you so much.
Thank you very much indeed, John. Real pleasure to take this forward. And in the next 15 minutes, I'll deal with the societal impact and make the point that, and because I'm an infectious disease doctor, I'm going to concentrate on public health challenges that come in the form of pandemics and epidemics, and say that pandemics impact society both directly and indirectly. And the societal impact of major public health issues can be viewed across multiple levels. So individual, family, societal, and international. I'll try and touch on all of these. And to do this, I'm going to use two illustrative pathogens that have ravaged the world in the last 40 years. So the one being, of course, HIV, been with us since 82, 78 million people infected, 39 million dead. And then SARS-CoV-2, we've had since December 2019, 250 million cases and 5 million dead. So HIV, perhaps the longest with us, and some would say we are in the last mile. We've had periods of devastation, discovery and action, and as I say, now, depending on how optimistic or pessimistic you are, it might be described that we are in the last mile. In the country of South Africa, we really have borne the greatest burden of this epidemic. Today, we have almost 8 million people living with HIV, but we have seen an enormous amount of mortality and morbidity, mostly in this case, amongst our young adults and children aged 0 to 2 who have borne the brunt of this particular pathogen. And as we all know, that post-infection, this is a lifelong infection with no possibility of cure under the current circumstances. Losing young people in the prime of their life means that we end up with orphans. And here you see around the world the impact of AIDS in terms of orphans. And here in this country, again, tracking the increase in infection in the country has been the numbers of people who have died and the people who have been orphaned. And most significant, of course, maternal orphaning, which is really leads to serious societal impact in terms of the current generation and the next generation. And I'm reminding you that, of course, this pathogen is transmitted vertically from mother to unborn child. And again, we've made wonderful headway here with antiretrovirals, but still far too many children are born every year who are exposed to HIV in utero and may go on to carry the infection into their own lives. Again, antiretrovirals have made a big difference here. In the 20 years ago, 1 in 2 of those babies would have died. Today, they are living into adolescence, but we have this growing population of young people living with HIV who have lived with HIV their whole lives. And of course, that has a societal impact as well. This category, this population, we have not been able to shift mortality in significantly. So AIDS continues to be a leading cause of youth mortality in this part of the world, along with tuberculosis, and then non-natural causes highlighted there for you in that slide. So around the world the one population we have not really made an impact on in terms of reduction in death is adolescents, young and middle and older adolescents. So thinking about the demographic impact of HIV on families in sub-Saharan Africa, there's this paper, now a little bit old, but I think pointing out what can happen in terms of direct impact. So HIV and AIDS has an impact on fertility, reducing fecundity. It increases widowhood with all of those societal impacts. It leads to household dissolution. Households that are larger and can move to extended families have been able to buffer, but of course the impact on maternal orphans has really hit this part of the world and continues to play out in our subsequent generations. And of course, luckily, due to extended households, perhaps we haven't seen quite the same effect in terms of proportions of households headed up by children or skip generation households. Moving to the impact of politics and ideology, I do want to say throughout this, and I'm hoping in my section of the talk, I think you saw it in John, but also in this section, that politics do play a huge role in these public health crises. And in the case of HIV, we've seen a lack of progress in terms of politics and ideology. So where criminalization and discrimination of key populations that are particularly burdened by HIV, then we've seen less progress. It leads to non-disclosure, exposure, a reduction of people being able to access services. And of course, even though today we have tools that can now be handed out and reduce the impact of HIV, because of stigma, because of ideology, because of politics, we often still are unable to reach some of those places where the epidemic now still remains far from over. Let's turn to the direct impact of COVID. We have seen 3 waves on the continent, each led by a different variant of concern. When I drill down in South Africa, that certainly has been the case very clearly. You can also see how we've had lockdowns, restrictive lockdowns that have been related to each of these surges of epidemics. So it hasn't been just one steady hit, it's been surges of the epidemic. And whilst we have an official death rate of 90,000 odd, just under 100,000 people having succumbed to this epidemic in the last 18 months, we know that the death rate is actually 3-fold higher. 260,000 have lost their lives, many of them younger than perhaps has been seen or related in other parts of the world. And this is just to make the point that excess deaths is a very important parameter that gives us a better handle on this continent of the impact of pandemics and epidemics, because our death notification may not always be as accurate as the real picture is. So let's move to some of the indirect aspects. And of course, along with these epidemics, with these infectious diseases, such as Ebola and of course HIV, comes stigma and the impact on communities because of this. And here I point out 40 years on in an epidemic, we still have very high rates of stigma, particularly on our continent. And this results in people taking up less services. So here, the illustration being less uptake of HIV. It also leads to less uptake of treatment, less adherence to treatment, less uptake of prevention strategies. And of course, we have to have approaches during these pandemics of how we can reduce stigma. We have had TB for 100 years on this continent. And yet even there, we continue to see stigma and the impact of stigma holding people back. We have, of course, seen it with coronavirus, that stigma has led to people not seeking medical care, not adhering to interventions. And I've already pointed out that tuberculosis, our other epidemic, this continues unabated. Our own response to COVID has, of course, had enormous impact. And John has already hinted at the economic impact, but I want to say that the restrictions, the very restrictive lockdowns, which were part of our non-pharmaceutical interventions, have, of course, had a huge impact. And to his point around the Gini coefficient, the pandemics often lay bare inequalities, even within country. So again, here in sub-Saharan Africa, those who are more affluent, those who are better off, being able to cope better with the impact of the restrictive lockdowns than individuals who find themselves in low socioeconomic settings, where not being able to get to work may actually result in no pay or loss of employment. And that, of course, has led to poverty. So it is estimated by UNICEF that a further 140 million children in developing countries are projected to be in households living below the poverty line. And because we've had to keep them out of school, of course, this has led to an impact on schooling, education, and pediatric well-being. So approximately 150 million additional children living in multidimensional poverty, and 463 million children unable to access remote learning because of COVID-19 restrictions. So the impact of COVID has really played out in a variety of different ways. And here I highlight another unexpected or perhaps expected consequence, the global rise in gender-based violence during the COVID-19 epidemic. And in the interest of time, I won't read those quotes, but really heart-rending descriptions by women in South Africa of the experience of the lockdown, an increase in economic insecurity, alcohol consumption increasing, leading to women being trapped in their households and experiencing gender-based violence. Now, I want to just show another indirect impact, and this is the collision of epidemics. So COVID-19 and its impact on other healthcare provisions, such as, for example, HIV. And COVID-19 and its restrictions had the potential to impact every single aspect of our HIV care. Luckily, on this continent, we had already moved quite a lot to a differentiated service delivery model, where people living with HIV are able to access multi-month dispensing, pick up tablets maybe once every 3 months, go to non-clinic-based settings for their treatment. And that certainly offset some of the impact of COVID-19. But we did see an impact of COVID on, for example, HIV testing with a 22% drop. We saw a 27% drop in medical male circumcision, 11% reduction in people accessing HIV programs, and almost 5% drop in mothers receiving treatment to prevent mother-to-child. TB also took a hit. Here you see up to 60% decrease in TB referrals during the COVID period. And here in this model, 200,000 additional stillbirths may occur potentially because of a reduction in services due to COVID-19. And then other vaccines may also be affected. This very concerning statistic, again from UNICEF, that 80 million children under the age of 1 in 68 countries may miss out on receiving life-saving vaccines. My last few minutes, I'm going to pay attention to the politics of these pandemics, which have an impact. We know AIDS has always been political. Access to treatment being foremost here, not being able to bring life-saving treatment into the third world because of cost and because of treatment, because of pharmaceutical restrictions. And as John alluded to, we're seeing exactly the same pattern playing out now, 20 years on, with the COVID vaccines. We know that society has played an incredibly important role in advocating for this and being activists in this regard. And you can see post the South African phase of denialism, ARV initiations taking off, thanks very much to community-based structures such as the Treatment Action Campaign, with a complete turnaround on the trajectory of death that was as a result of HIV. So the inequality that we see in these kinds of public health crises is really of pandemic proportion, the haves and the have-nots, the North and the South. And as John so beautifully showed, now playing out in vaccines, with G20 members now having received 15 times more COVID vaccine doses per capita than sub-Saharan Africa. And we truly are the slowest in the rollout of vaccines in the world here in sub-Saharan Africa. Only 2.3% of people in low-income countries have received at least one dose as of today. So there are movements such as this, again, global society, community stepping forward to say what can be done. And here the People's Vaccine calling for a campaign for a waiver of the TRIPS, trade-related intellectual property rights, to allow patents to be moved, manufacturing to be expanded, as John was saying, and South Africa and India leading the way in this regard. Of course, what do we stand to gain from global pandemic solidarity? Much. There are gains to be made in terms of health, the global death toll. There are gains to be made economically in terms of supporting global recovery, mitigating supply chain interruptions, and of course, importantly, socially, strengthening global ties and allowing us to stand against the perpetuation of deepening global health and economic inequalities. And I want to underpin, as I highlight society, as community has played a very important role in both of these pandemics, through activism, through advocacy, through education, and actually provision of services. So here, again, a reminder of TAC and what has been done, to remember that community has given us many solutions for HIV, and it can do still in the future. We can't afford not to engage with community. Community has helped with differentiated service delivery throughout HIV, providing community opportunities to reach people. And we saw in COVID how community stepped forward through these action networks, through ways of helping each other and coming to the aid of in a sort of Ubuntu fashion, to make sure that we mitigated some of the very severe unintended consequences. So activism and advocacy is such an important part of the pandemic response. And that raises, for me, my last comment, which is around vaccine hesitancy on the continent today. That this, we know, is fed by anti-vaxxers, but also complacency, a lack of confidence in vaccines, and maybe a lack of access. And again, the very important and new role of social media, disinformation, or the counter of that, the opportunity to provide good information to people through social media channels. So, John, ladies and gentlemen, colleagues, my last few thoughts here are the lessons we've learned from these two pandemics, or these two pathogens that have hit the world in a pandemic way, is that pandemics are political and politicized, but science must guide all interventions, therapies, and policies. Basic principles prevail. We've got to understand the disease, treat the infected, and stop transmission. Impact can be seen both directly on, and health resources, of course, are key, as John showed. There are also indirect consequences that we need to build into our responses. They involve also behaviors, contexts, and settings. And it's important that we bring those most affected into our conversations to see how we can provide differentiated responses. Communication, education, good information is absolutely important. And of course, innovation is so important. We believe innovation can happen on this continent as well. Global solidarity and equitable access is something we should continue always to advocate for. And meaningful outcomes usually need bold steps, resources, and above all, enduring compassion. And I'll end there. Thank John for his terrific input, and thank you all for listening.
Let me thank you most sincerely from all of us here, Professor Linda Gale-Becker and Professor John Ataguba, for helping us to understand better the cost of the pandemic. This is certainly a very good way to walk into the next session, which will be focusing on the economics and societal impact of global public health challenges in Africa. So we've more or less discussed at length the science of the pandemic. We want to give it a new twist, looking more intensely at the societal and the economics of all of it. For this second plenary session, the chair is going to be Professor Sizwe Mabizela. Professor Mabizela is the Vice Chancellor at Rhodes University and also the co-chair of the Arua board. Dr. Mabizela is the prior to assuming this position in 2014, he was the Deputy Vice Chancellor, Academic and Student Affairs at Rhodes University. He's a mathematician, and his research field is abstract approximation theory, a subfield of functional analysis. He has published widely in his field of research in both national and international journals, and has produced 3 lecture notes series. He has presented numerous scientific papers at national and international conferences, workshops, and seminars in the field of functional analysis and approximation. He obtained his PhD from Pennsylvania State University. Please join me in welcoming Professor Sizwe Mabizela.
Thank you very much, Professor Ritia. Welcome to all the participants and the attendees to this plenary session. Let me start by acknowledging with much appreciation the keynote speakers, Professor Linda Gale-Becker and John Atakuba. They have really provided a very important framing of this session that we will have right now. So thank you to both of them. They touched on a number of issues pertaining to pandemics and counting the cost thereof, touching on issues of stigma, politics, and so on and so forth. In this particular session, we will drill deeper, and this session is themed the economics and societal impact of global public health challenges in Africa. So to both Linda, Gail, and John, thank you very much. Our speakers in this plenary session are Professor Jane Mariara, Professor Emma McIntosh, and Professor Robert Osei. I'll introduce each one of them fully when they're about to address the conference. Each speaker will have 20 minutes to address the conference attendees. I invite all attendees and participants to note their questions and pose them after all the speakers have made their presentations. Those who are joining the conference virtually can post their questions in the chat box. Our first speaker in this plenary session is Professor Jane Mariara of the University of Nairobi. Professor Jane Kabubo Mariara is the Executive Director of the Partnership for Economic Policy and a Professor of Economics at the University of Nairobi, Kenya. She's a member of the Central Bank of Kenya's Monetary Policy Committee and the German Institute of Global and Area Studies Advisory Board, among other roles. She has more than 30 years experience in capacity building and research and has served in various corporate and scientific advisory roles globally. Her research interests include climate change impacts and adaptation, poverty and inequality, youth and women empowerment, multidimensional, and child poverty. Jane has published widely in leading economics journals. She holds a PhD, master's and bachelor's degrees in economics from the University of Nairobi. I have the great pleasure of inviting Professor Mariara to address the conference on Partnership of Economic Policy, Perspectives of Crises, Impact, and Policy Lessons from Emerging Research in Africa. Over to you, Jay.
Thank you. Thank you very much, Chair. And thank you very much, Arua, for giving me this opportunity to present in this conference. I'm going to share my slides. I hope you can see them. As I've been introduced, I'm Jane Mariera. I'm going to be the first of the speakers in this session. And as the chair and Ernest have indicated, I think John and Rita have already done a very good job at talking about some of the impacts, both economic and societal, of the crisis. They have brought in the issue of HIV/AIDS, and now I think there was also a bit of touch of Ebola, and now the COVID crisis. And my talk will be focusing on the crisis, on the pandemic. I'm trying to change to slideshow. So my topic is titled "The Perspectives of Crisis Impact and Policy Lessons from Emerging Research in Africa." And this is actually work that has been done at the Partnership for Economic Policy. So in a Partnership for Economic Policy, just first to give the perspective of the work, we do work believing that in-country development challenges require locally devised solutions. And therefore, all the work that we do, we ensure that it's locally based, and we are looking for local solutions, and those solutions will be used at the ground. And I will talk about this a bit later when I'm presenting the work. And also just to say that what we do is produce high quality research from a local perspective. I've already alluded to that. Then we build bridges between research and policy. We strengthen local capacity for researchers and policy engagement. We boost project feasibility and impact on policy through, of course, sponsorship and mentorship of both researchers and policymakers, government officers, and so forth. And then finally, we create connections for knowledge sharing across the group. And I'm very happy to say that actually one of the keynote speakers, John Ataguba, is very closely associated with the Partnership for Economic Policy also. So coming back to what I want to talk about today, we have quite a lot of work that is going on in PEP, or in the Partnership for Economic Policy, on COVID research, but I'll focus my next few minutes talking about what we call our core project. And this is a COVID-19 Responses for Equity, a project that is funded by the International Development Research Center of Canada. This work, we are carrying it out in 11 countries, 7 of them in Africa, and I'll give highlights of a bit of this work. 2 Latin American countries, and 2 countries in Asia, so that in the end we are able to compare the perspectives across the group. Of course, you could say that doesn't look representative because we have more countries in Africa, but the point is that with the budget limitations, we are still able to pick lessons from across the group. So the countries of focus in Africa, we have Benin, we have Cote d'Ivoire, we have Ethiopia, we have Ghana, we have Kenya, we have Nigeria, and we have Zimbabwe. So for all these 11 countries, the objectives are related, but then there's divergence in the approaches and in the sectors of focus. But broadly, we have 4 objectives in this research, which we started in 2020. It's ongoing, and hope that we will complete it by 2022, 2023. So in the first instance, what we are trying to do is to assess the COVID-19 impacts and effectiveness of existing and potential policy responses in the different countries. We are also trying to provide evidence to support or to inform the design of inclusive adaptation and recovery policies. What I mean there is that because it's the local government, the government on the ground that must design the inclusion policies, how to adapt, how to recover, and so forth. Then what we are doing is trying to see how we can work with the local government officers to provide evidence that actually with proper design, these policies can work. And then we are developing country relevant tools to guide policy design and reform. Of course, recognizing that different countries must respond to the crisis differently, depending on the conditions of on the ground. And here, what we are trying to do is to familiarize local researchers and government officers with these tools so that then they can use them to design the relevant policies at home. Finally, we identify general lessons that can guide inclusive response and recovery policies, not just in these countries, not just in Africa, but in other developing countries as well, so that if we pick the lessons, for instance, from Africa, we can see what is it that can work in Latin America, what is it that can work in Asia, and how do we crossbreed that? How can the lessons that we are picking from Latin America work in Africa, work in Asia, and so forth? So basically, that's the focus of the work that we are doing. In terms of the approach, I'll not go into the details of the scientific approach, but basically we have three in two approaches. We have simulations or micro simulations from the more general equilibrium modeling point of view, and also simulations from more micro approach. On one hand, those are two approaches, but targeting the same. And then we have field experiments of policy responses and interventions, but the field experiments are only in two countries, that is Benin and Cote d'Ivoire. The others, in the other countries, is where we do simulations using both micro and macro approaches. Because of interest of time, of course, I wouldn't have time to go into the scientific methodology, but I do refer you to our website where you get insights on all the 11 different country studies that I'm talking about. And as I've already mentioned, the way we are doing it, this is locally led collaborative research, whereby the project teams are composed of local researchers. They're the main ones who are doing the work. Then we have government officers who are teaming up with the local researchers, but then we have international researchers who are working with these teams, but more at mentorship than assuming that they know the local context, maybe bringing more of the scientific aspects than the local context. And two, the teams engage in early and periodic consultations with target government institutions. So it's not just the government members that are involved in this research, but they are also doing very extensive consultations with the government, because our recognition is that the research that we must support and the solutions that come out of them must really be relevant and practical. And I think we have seen this in the case of crises such as this, because then we cannot have kind of theoretical solutions, because if we are talking about intervening on the ground, trying to adapt policies to alleviate the crisis impact, then we must have practicality on the ground, and therefore the local expertise is very important. And really, what we have seen, maybe I'll mention here this instead of at the end is that some of the projects that we are having, for instance, the one for Zimbabwe, we find that co-production has really been important in terms of increasing the ownership of resources by the target stakeholders. And therefore, what happened is that our team in Zimbabwe is now closely working with the National COVID-19 Task Force. And this was simply because they involved the government at the beginning or at the design of their project, and the government realized that actually they could get solutions for their local problems or part of their local problems from the team. And so government and policymakers are increasingly receptive to the evidence-based research to inform policy making in the case of now the COVID-19 crisis. And then we also have the project in Nigeria, whereby our team's engagement with the National COVID-19 Special Committee also resulted in direct use of the evidence in policy, advisory, and decision processes. And the team is still working with the Nigerian, part of the Nigerian government for that purpose. But coming back to more of the economic and societal impacts that I think John Reader has brought out very clearly, I'll just give a summary of what we find in the countries. We find that generally, the most affected groups and the impact channels or impact mechanisms actually differ between countries. We cannot say that there's one size fits all. We cannot say that the effects are uniform, but we find they differ, but they are closely related depending on maybe the conditions on the ground and maybe the sectors of focus. For instance, in Ethiopia, the results that we have, this was a micro simulation study, suggests that there was an 80% increase in poverty in the sample in question, which was driven by changes in direct income and food prices. And what that study shows is that actually the very poor were very hard hit by increase in food prices. And then the study in Ethiopia also shows that the most affected are the poorest, those at the bottom of the distribution. Again, this was alluded to by John, and that women and farm households were also very adversely affected because of shocks. They are very vulnerable to shocks, and therefore they are adversely affected. And then in Kenya, this was a kind of a micro simulation, computable general equilibrium kind of study. The results show that the impact of the crisis is mostly through reduced employment, especially in the service sector. And when we talk about service sector, we know that what was mostly affected in Kenya is accommodation, restaurant, the tourism sector, hotels. Very big hotels have had to close down. And for close to 18 months, there was very little operation. And so those who are working in those sectors were very adversely affected. And then secondly, the most affected were higher income households, those that actually could not maybe survive in the more informal sector, and also workers with secondary education, again, if they are working in the service sector. Another finding is that we found that it is very important to target beneficiaries of the crisis policy responses, or what we call maybe in some it's economic stimulus package, in others it's kind of social assistance. But this is very important to alleviate the overall impact on national economies. Again, what we find about this in Ethiopia is that the government's productive safety net program prevented about almost 1 million people from sliding into poverty. I think we've seen earlier that one of the effects in Ethiopia were the poor being affected by food prices. But we are saying those who are under the safety net then were actually cushioned from sliding back into deeper poverty. But we also found that the impact would have been much larger if or rather the impact of the safety net program would have been much better if it was better targeted at the most vulnerable group. So one of the policy responses or policy prescriptions for Ethiopia is still to revisit the way they were targeting the vulnerable groups. Then in Zimbabwe, we found that the mitigation measures were helping, but they were mostly helping the women even more. This could be because of the sectors in which women were in, because the mitigation measures, some of them were ensuring that there will be no layoffs in some sectors, or to cushion the incomes, to prevent, to lower taxes and so forth. But it seems like women were advantaged in the case of Zimbabwe. And then in Zimbabwe, we also find that the side effect of the mitigation measures is the negative impact on investments in the long run, therefore penalizing future production. Of course, the issue here is that the kind of targeting measures that were put on ground are more concerned with the present situation, cushioning households for present consumption or for the short term, but then not supporting long-term investment. Of course, I think one of the things that people have been saying, especially in the poorer countries, is that it's with the COVID crisis, the focus has been more on staying alive than worrying so much about the future. So it doesn't matter how much income you have today, so long as you can keep alive, hoping that once the pandemic is gone, then you can go back to better times. Then we also learned that women are generally disproportionately impacted by the negative effects of pandemic in some countries. We've seen that in some cases in Zimbabwe, for instance, the policies put on the ground were good for women, but yet the impact itself may have been worse. So, for instance, what we find is that in Nigeria, female employment actually declined more than for men, and in the long run, there's evidence from the study. This is a macro modeling project, that the gender employment and wage gap would actually widen, where women would become worse off unless policies are put in place. Then also we found that for Zimbabwe, women are facing the biggest impact through income losses, food insecurity, and caregiving burdens. Of course, except where the mitigation measures actually favored women. Ethiopia, women are more likely to engage in sectors that suffer higher income shocks due to the pandemic. We've already mentioned those sectors. The only difference that we found, or the only exception we found, is in Kenya, where the results, again, this is macro modeling, seem to imply that both men and women, or employment for both men and women, declined under the COVID-19 shock, but the decline seems to have been more pronounced for men than for women, which is surprising. But given the kind of social accounting metrics we are using and the data, it seems to imply that the issue is that women seem to be more involved in less affected sectors, that is agriculture and food industries. I think there's also the theory that maybe women were also better able to adapt to the crisis than to men. Then coming to my almost last slide, what can research teach us to inform policy in real time? Maybe just to mention that, as I said, I focused more on the studies that we have done in Africa, but I said we have other studies in Latin America, in Asia, and we also have studies outside this particular group of studies. But the lessons that we are picking, maybe for Africa, from the other projects, especially the ones in Latin America, is that one of the things that we need to do if we are going to cushion the poor is to combine maybe direct cash transfers with employment support, so that then we have a bigger kind of economic stimulus that can cushion the households from the shocks. Then also, we run that the depth of the crisis implies broad target population again. We should work as much as possible to minimize the exclusion era at the expense of inclusion era. Social exclusion has its own impact, especially on the poor. And then it's also important to incorporate gender dimensions in government assistance. I think we've already seen the effects that we have in different countries. So finally, to conclude, what I would say is that on the social effects of the crisis, I think this was already brought up very clearly by John and Rita. We need to increase, it has led to increased poverty and inequality. We have long-term effects, for instance, loss of human capital. Education for children has been adversely affected, especially among the poor, where we know that the literacy rates are already very low, and there has been hysteresis in employment for adults. Then we know that the gender impacts have been such that women are mostly affected, falling into unemployment and poverty. On other lessons that we run is in terms of the fiscal impact. There's evidence from some of the studies that there has been a recession, which of course now may be abating a bit, but we find that farm and employment destruction has taken place in quite a number of countries. There have been loss of revenues due to, of course, a recession in the countries when the value chains were really affected by the pandemic. There were massive losses of revenues. Some farms had to close. There are lost schools, especially private schools, small private schools in some of the poorer countries, including Kenya, have had to close down, meaning also loss of employment, wasted opportunities for children as they try to transit to other schools. Then there's increased expenditure, especially emergency social and employment aid, utilities and other subsidies. We've already spoken about that. And finally, maybe something that we've not brought up from the African studies, but is coming up from the other studies, is a reduction of exports because of the disruptions in value chains and also the balance of payment risks. So with that, Chair, I want to thank everyone for listening, and also again for Arua for this opportunity. Thank you.
Thank you very much, Professor Mariara, for your very informative presentation. Colleagues, our second speaker in this session is Professor Emma McIntosh of the University of Glasgow. Professor Emma McIntosh is the Deputy Director of Glasgow University's Health Economics and Health Technology Assessment, and the Director of the UK's NIHR Global Health Group on Arthritis. Emma holds an MSc degree in Health Economics and a PhD in Economics. Her methodological interests are in the area of economic evaluation, evaluating public health interventions, global health economics, stated preference methods, and cost-benefit analysis more generally. These methodological interests are applied across a large portfolio of research projects, which are funded by the NIHR, MRC, EPSRC, and other funding bodies. Emma has published over 100 peer-reviewed health economics papers, co-authored 2 books, applied methods of cost-benefit analysis in healthcare, and more recently, applied health economics for public health practice and research as part of Oxford University Press's handbooks in health economics evaluation series. Colleagues, I have a singular honor of inviting Professor McIntosh to address the conference on the health, economic, and societal burden of musculoskeletal disorders in Tanzania, results from a community-based cross-sectional survey. Over to you, Emma.
Thank you very much, Professor Rosabilla. I'm just going to share my screen, and hopefully you can all see that. Okay, so thank you very much to Arua for inviting me to deliver this talk. It's a very timely talk because we're very much amidst the full-scale analyses of these pieces of research. So today I'm going to give you some of the initial results. But it's been really interesting actually already listening to John and Linda and Jane talking about the economic impact. So it's really nice to be able to contribute to that. So I'm going to talk today about my global health research group on estimating the prevalence, economic and societal impact of arthritis in Tanzania, a mixed method study based at the University of Glasgow. So yeah, I'll skip over these details. Okay, so our key collaborators are our colleagues in the Kilimanjaro Clinical Research Institute in Tanzania, led by our co-director, Blandina Mbaga. And she brings with her team clinical and social science expertise to our multidisciplinary team based at the University of Glasgow. We're also working with the Northumbria Healthcare Trust and the University of Newcastle. So let's go straight into the statement of the problem. So 2010, a global burden of disease study reported that musculoskeletal diseases account for about 20% of all years lived with disability in low and middle income settings. Significantly contributing to this burden is arthritis. Years lived with disability attributable to osteoarthritis alone rose by 75% from 1990 to 2013. And in Tanzania, a complete lack of data exists on the epidemiology, the economic and quality of life of arthritis. So we know that Africa is currently facing a preventable crisis caused by the rapid rise in people developing non-communicable diseases. And this brings with it, as we've heard today, not only clinical, but economic, societal, and quality of life impacts. The measurement and valuation of these impacts is needed so that we can inform policy about how best to intervene. In Tanzania, non-communicable disorders account for about 27% of all deaths. However, the focus on NCDs has been dominated by other diseases such as cardiovascular, cancer, and diabetes, with very little attention paid to arthritis. This is very much out of proportion to the impact that arthritis has on disability. So what's our global health group doing? So to understand the distribution and impact of arthritis in Tanzania and to inform prevention and intervention plans, we have conducted population and hospital surveys to establish the prevalence, economic and quality of life impacts, and to understand the lived reality of arthritis. We've carried out qualitative research to explore understandings of joint pain and to understand the lived reality of arthritis. We've identified and tested methods to measure quality of life and healthcare resource use in people with arthritis. And we've also trained early and mid-career Tanzanian researchers and clinicians in conducting research. And finally, we're in the middle of developing sustainable capacity in terms of teaching and resources going forward to leave a bit of a legacy with our Kilimanjaro colleagues on tackling a wider range of non-communicable diseases problems. So why is health economics so important for our global health research group in arthritis? So as I said already, musculoskeletal conditions are the second most common cause of disability. Rheumatoid arthritis is the most common type of inflammatory musculoskeletal condition. Quality of life in these patients is particularly low, much lower than others other non-communicable disease patients. And there are very important broader impacts of musculoskeletal conditions, healthcare costs, productivity, quality of life, and well-being, which are often overlooked. So for intervention, implementation and evaluation purposes, we need to establish the likely costs and cost effectiveness of interventions alongside quality of life. Obviously, the long-term goal is to have universal provision of healthcare, and hopefully our study will inform policy developments and the need for services and the importance of disease management for quality of life improvements and income and productivity improvements. So the current situation in Tanzania, very limited rheumatology capacity. At KCRI in Tanzania, any identified patients tend to fall under orthopedic trauma or general internal medicine. So there's very little specialised service for rheumatology, and there's very limited treatment options available. We are linking in with the African League of Association for Rheumatology, the AFLAR, and so we're staying in touch with them around distribution of our results going forward. So just briefly, our methods, we're pretty much using two methodologies. We're using qualitative methodology and quantitative. So the qualitative approach is to use rapid ethnographic assessments, semi-structured interviews, and focus groups. And this has very much provided the grounding to our study. Our second stage was very quantitative. And I will give you some of the initial findings from those qualitative assessments just before I talk about the community survey results. Yes, and the quantitative element is a hospital and community survey with 3-tier screening, which I'll talk about shortly. So, community survey. So the sampling strategy, because I know there's quite a lot of statisticians and economists on the call. So we conducted a community survey over 1,391 households, 5,500 individuals in rural communities in the High District in Tanzania, plus one urban community, Majengo. And we used a 2-stage cluster sampling method with probability proportional to size. We had selected 15 out of 65 villages, clustered, selected with replacements, and 93 households selected from each cluster. We were very lucky, we employed the Balozi infrastructure, which is currently in place to enumerate the households and to inform the villages about the aims of the survey. And the statistical analysis will take into account the survey design, including adjusting for within cluster homogeneity. So, I just want to this is a very heavy slide, so apologies, but I just want to outline the fact that we had a 3-tiered system in our community survey. So the first tier was very much around collecting the demographics and basic quality of life and disability assessment scales, and a short economic questionnaire for the entire study population. Based on the screening, so GAL, so gait, arms, legs, spine, the dog's crying in the background. We've got, once they've been screened and they were GALS positive, which is a sort of broad musculoskeletal screening instrument, they were then given a tier 2 survey, which then went on to administer a more specific regional examination of the musculoskeletal system screening tool. And then that was followed by the health assessment questionnaire and some other instruments, including the long health economics questionnaire. And finally, tier 3, where people were diagnosed with REMS positive, they were then given further tiering, which captured, which took blood samples, ultrasound, height, weight, and a little bit more specific clinical information. So just so you can see, there was this 3-tiered, depending on the results of this initial tiering. Okay. So the health economics questionnaire, so we're very much tailored to answering specific research questions. So within the questionnaires, we had labour questions, health questions, income, wealth, and lots of other questions around unforeseen circumstances and catastrophic expenditures and those types of things. In the interest of time, I won't go through it, but what I wanted to flag up were the health economics research questions, which were part of our study. So what are the quality of life and capability well-being impacts of arthritis? What are the productivity and income impacts? What are the health-seeking patterns? What are the health-related expenditures? The cost of musculoskeletal disease and arthritis? And finally, is rheumatoid arthritis a predictor of catastrophic expenses? So I just want to quickly take you through some of these initial findings from the qualitative study before I talk about the results from the quantitative community survey, just because they're super interesting. So we wanted to find out how arthritis is understood by community members, healthcare professionals, and patients in Tanzania. So we conducted a rapid ethnographic assessment, which comprised 60 brief interviews within 2 communities and using lots of photographs of the built environment. We conducted interviews with community leaders, healthcare providers, community members, and our qualitative team built a typology of different words used for joint pain. There we go. So these are just some initial findings, just wanted to share with you before I talk about the survey. So what is joint pain and what causes it? And this is, so the naming in Tanzania, there was words used such as cold disease, old age disease, disease of the joints. Causes were talked about were exposure to the cold, old age, alcohol and red meat consumption, witchcraft, demons, sitting in one position, gender, injuries and falls. Who gets joint pain? Older people were identified by the majority of informants as the main group of people. Women were also identified by large numbers as those commonly experiencing joint pain, and occupation was also mentioned. How does joint pain affect people? Lots of discussion about economics in the family. The disease has lots of negative consequences for the individual, and so on. It causes new conditions, especially for older people when they have back pain. So really interesting findings there on the qualitative work. How does joint pain affect people? Loss of mobility. People with joint pain cannot move fast, can't work. So these economic impacts around mobility also being picked up on. Other consequences linked to death and so on. What do people do about joint pain in Tanzania? So people with joint pain attend the hospital to see medical doctors. They buy medication from pharmacies. They use herbal remedies, and traditional medicine was also prevalent. What do people do about joint pain? So exercise was mentioned. People talked about witchcraft and spiritual solutions. So our preliminary findings show that there were 10 languages used. There was 154 words associated with joint pain. Understandings of joint pain are very syncretic, a mixture of folk and biomedical conceptualizations, with responses being biomedical, herbal, spiritual, witchcraft, and exercise-based solutions. And there was lots of dominant narratives about who was affected by joint pain. We talked about older people and women, mapping very closely to the epidemiological picture in our pilot survey, but also more broadly in the global literature. Yes, and the consequences of joint pain were diverse, but they were well understood, and there was a real understanding that loss of mobility leads to socioeconomic consequences that reverberate through the community and can lead to further health problems. So let me just take you on to the community survey findings now. I will say these are ongoing analyses as of this month and last month, so these estimates are likely to change, but I just wanted to give you a flavour for the results coming out from our large community survey. So going into basic demographics, and I know we're short of time, it's going to take you straight down there to the GALS positive and the REMS positive. So remember, the GALS positive is a very broad screening instrument used for musculoskeletal conditions, and the REMS positive is a much more specific screening tool called the Regional Examination of the Musculoskeletal System. So we can see there that initial prevalence estimates are around 5.9, almost 6% for REMS positive and around 8% for GALS positive. So really interesting findings in this group. And going on to the quality of life. Now, I don't know if any of you are familiar with the quality of life EQ5D tool. It basically rates health on a scale between 0, which is death, and 1 is full health. So full health would be you're living your life in full health, and your utility is reflected in that. Now, what we can see here is that those, if we just look at the blue columns here, those who are GALS positive, those who have tested positive on the screening tool from having musculoskeletal problems, their quality of life is much less there. So 0.82 as compared to 0.97. So compared to those who have not had a GALS positive diagnosis, if you like, and similar with REMS positive, where their quality of life is much less than those with a negative diagnosis. So we're seeing an almost 20% reduction in quality of life from those screening tools. There's people that are testing positive to having these conditions. So let's look at how that impacts productivity and healthcare expenditure. So again, we're just looking at here the GALS positive, and we can see that those people who are GALS positive have less work days than those who have GALS negative. So this is work days in the past 3 months. And what we can see is that those who are positive are having less work days. And then when we ask the question about whether work has been affected in the past 7 days, we can see again that those with GALS and REMS positive are being affected more than those negative. We also asked about other activity affected in the last 7 days. So that's to account for people who are not working but have other valued daily activities. And the same pattern is arising here as expected. So we expect this, but what we've done in our study is we've been able to quantify it. And then looking at the total healthcare expenditure reported by our participants, we can see that those who have a GALS positive or a REMS positive diagnosis are spending a lot more on healthcare expenditure. Now, there's a large distribution around this. There's quite a lot of variation, so we've got some more analyses to do on this, but we can see already the trends of spending caused by these healthcare conditions. So yeah, so just a summary of the findings there. We have got these prevalence estimates for the first time using GALS positive and REMS positive. And we can see that we have a prevalence between about 6% for REMS positive and around 8.5% for GALS. But there are associated factors. These are ongoing at the moment, these analyses, but older you are, if you're female, if you have a higher BMI, and so on. These were all predictors. And other things such as taking exercise were negatively associated with the prevalence. We've talked about the quality of life values there, and we've seen that sort of approximately a 20% reduction in quality of life due to a GALS or REMS positive diagnosis. So significant reductions in health-related quality of life, and also clear productivity impacts on working days, time taken off due to illness, other activities, and household spend. So just finally, I'm not sure how much time I've got left, but I'm thinking in the last few minutes. I just want to talk about the fact that our study has also conducted training and capacity building. We've had a bunch of people attending EULAR courses. This is the European League Against Rheumatism. We've had a number of bursaries, and we've funded grant writing courses, clinical skills, ultrasound scanning, and we have also set up a new musculoskeletal clinic at KCMC. Okay, and yes, we have a number of donations of the project equipment, such as ultrasound machines, freezers, and tablets, and they've all gone to our colleagues in KCMC. So there we are. There's all our team. Yeah, and this. Yeah, there's the clinical training going on, and this was the trip, the fieldwork trips, and a bunch of us having a look around the labs there with Blandine and Baga in Tanzania. So I mean, there's so many. We're so grateful to all these participants and our researchers and our team. So lots of thank yous, but I'll stop there so I can pass over to the chair. I hope that was all clear, and the dogs crying in the background weren't too off-putting. Sorry about that.
The dog was making an important contribution. Thank you so much, Emma.
You're welcome.
Thanks for that beautiful presentation. Let's proceed to our third and final speaker in this plenary session, and that is Professor Robert Osei of the University of Ghana. Professor Robert Dako Osei is an associate professor in the Institute of Statistical, Social and Economic Research at the University of Ghana in Legon, and also the Dean for the School of Graduate Studies at the University of Ghana. He also heads the Ghana node of the Arua Center of Excellence for Inequality Research. His main areas of research include evaluative poverty and rural research, structural transformation and its implications for poverty and inequality, and other economic development policy concerns. Colleagues, I have a great pleasure and a privilege to invite Professor Osei to address this conference on growth, poverty, and inequality post-COVID. Over to you, Professor Osei.
Thank you very much, Professor Madizela, and good afternoon, colleagues. Well, let me begin by saying a big thank you to Arua for inviting me. I guess I need to start sharing my slides. Oh. Okay. Okay, so thank you very much, colleagues, for the opportunity to present. And what I'm going to be speaking on, I haven't listened to the keynotes and also colleagues in this plenary session. I know that some of the issues have already been touched upon. But I'm going to be sharing some of the work that the African or Arua Center of Excellence for Inequality Research have been doing in the area of poverty and inequality, but also trying to understand what the implications of the COVID has been for generally poverty and inequality. And I would like to start with a quote by Jeffrey Sachs. And this was Jeffrey Sachs just last week commenting on the Build Back Better Act that the US has been debating in recent times. And let me precisely quote what he said. And I read, "The COVID-19 pandemic has whipsawed the economy, both in the US and globally, more than any other shock since World War II. The swings in demand and supply because of lockdowns and government policies are bigger than the 1970s oil shocks and the 2008 financial crisis," end of quote. And I am bringing this up not because I'm going to be speaking on the BBB legislation, but essentially to try and then highlight the importance and sometimes I feel downplaying of the implications of the COVID over and beyond the health impacts. So after the health crisis, and I think that generally we do see that science is working very hard in trying to come to terms with the so-called new normal. However, in terms of economic policy, I think sometimes it just seems like it's business as usual. But if you relate that to the point that is being made by Jeffrey Sachs, he is pointing to the fact that the economic effects of this pandemic is as serious as any other that the world has actually seen over the post-Second World War period. And so I'm going to just share some of the ideas and some of the findings in terms of how the COVID has actually impacted the socioeconomics generally in Africa. And the discussion is going to be around two broad areas. One, the macroeconomy, where I will speak on the economic growth effects of the pandemic, but also the fiscal outcomes which have resulted. And again, in the earlier keynotes, some of these issues were touched upon. But the other arm that I'll be speaking on has to do with the human development effects of the pandemic, and more specifically, looking at employment and also poverty and inequality. Now, over the last, let's say, even 10 years, you find that for sub-Saharan Africa, economic growth seems to have been doing quite well for quite a number of countries. And so if you look at the graph that I have shown here for 2019, Sub-Saharan Africa, which is the gray bar, was growing at an average rate of about 3.1%. And indeed, what the literature also points to is the fact that between 2010 and then 2016, of the 12 fastest growing economies in the world, 6 of them were from Africa. Between 2017 and 2020, of the 12 fastest growing economy, 5 of them were from Africa. So from a growth perspective, the African countries were doing quite well until the pandemic. Now come the pandemic, and the evidence in respect of economic growth rates for the world, specifically for Africa, and also for the emerging economies, have all been taking a very big hit. And so you do see the negative growth rates recorded for this group of countries. 2021, the projection is that there is going to be some significant recovery. Although it must be said that part of this recovery is what is known as the base effect, the fact that the GDP has actually declined, and so the growth rates will seem to exaggerate how well the economies are doing relative to the pre-pandemic levels. So even though there seems to be some recovery, or there is projection of recovery, I think that the growth that Africa is experiencing is certainly a bit more fragile than it was pre-pandemic. And so the ability of the African countries to actually get back onto the development trajectory or window that they were operating, and probably even move a step further from there, will essentially depend on the lingering effects of the COVID. Now, again, in earlier talks that we've had, we do understand that even though we are getting used to living and working with the COVID, we are not out of the woods as yet. And therefore, we need to be mindful in terms of what the implications are for economic policy going forward. The challenge with the COVID also is that it is not just affecting growth, but it also have had very significant effects on fiscal outcomes. We know that even before the COVID, the general tax efforts, revenue efforts in Africa was not necessarily the best. The tax ratio for Africa was around 16%, 16.5% in 2020, compared to about 34% for OECD. And even the 16.5%, there is significant heterogeneity across the countries. And so you have countries like Nigeria having tax efforts or tax GDP ratio of around 6.3%, compared to, say, Cape Verde, which was doing around 21% of GDP. Now, on top of this already low but volatile revenue efforts was the fact that come COVID, the requirements in respect of government expenditures was significantly increased. And so there was increased demand for government expenditures. Unfortunately, for many African economies, the rigidities in government fiscals mean that it is not easy to actually switch expenditures around just overnight, because significant part of the expenditures are almost fixed and government can't do much about those. And so the discretionary component of government spending generally is limited. And so what it actually meant was that with the COVID, and you can see in these selected countries, and again, I just chose any 3 countries. Burkina Faso, pre-COVID, was doing deficits of around 3.5%. Come 2020, this jumped to over 6%. It is projected to reduce to 4.6% in 2021. Similar story with Nigeria, doing around 4.8%, increased by almost 1 percentage point. Again, it is expected to reduce in 2021. Now, of the countries that were growing very fast in Africa, Ghana was one. And if you look at the deficits in Ghana, 2019, it was around 4.8%. Come 2020, it jumped to 11.7%. And of course, it's expected to reduce, but again, to 9.5%, which in the opinion of many is still quite high. Of course, in the Ghana story, anybody who knows the fiscal story of Ghana knows that the deficits typically follow the political business political cycles. And so where you have election years, you tend to be less disciplined from a fiscal point. And so 2020 for Ghana, the jump there was not only due to COVID, but again, there was much more going on in respect of the fiscals. And so this already low tax efforts, plus the requirement for increasing government spending to meet the health needs, as well as some of the other social needs, particularly for vulnerable and poor households, meant that deficits were compromised. But not only were deficits compromised, it also had implications for the debt position of these countries. And so again, you find that for all these 3 countries, the debt GDP ratios actually increased over the period. Now, what this is telling us, and again, Ghana is standing out here in terms of the fiscal and indeed debt sustainability challenges. But the debt situation for Ghana, for instance, means that future fiscal space is generally compromised because, again, you would require significant proportion of revenues to actually finance the servicing of the debts. And I believe that currently, Ghana, for instance, is doing close to 50% of revenue. So there have been physical implications of this pandemic, which will linger on beyond the pandemic after we've actually been able to come to terms with the health aspects of the pandemic. Now, in looking at the social, economic, or the human development effects of the pandemic, it's important again to establish that prior to the pandemic, many countries, even though the extreme poverty rates remain rife, in Africa, many countries experience a decline in the poverty rates. And on average, in sub-Saharan Africa, between 1990 and 2018, poverty incidence reduced from about 56% to about 40%, sorry. But we also know that from some of the studies that ASA has done, we know that inequality has persisted in Africa. And so if you look at the Gini coefficient, it remains very high for many countries. Of course, South Africa is probably leading the pack with a Gini of close to 65% or 0.65. And so what the COVID came to do was to come and then, on top of the precarious situation that we had in respect of human development, it came to add to that situation. Okay, so an IFPRI model, which is a global CGE model, for instance, finds that a 1% change in growth as a result of the COVID, so an adverse change in growth, would increase poverty to between 14 and 22 million people. Already we've seen the growth rates for sub-Saharan Africa, which dropped from between 2019 and 2020 from an average of about 3.1 to negative 3%. Unfortunately, most of the people in the projection that is done by IFPRI will be in rural parts, and therefore that could also compromise food security in Africa. Indeed, researchers from Brookings Institute also estimate that for Nigeria, for instance, between 2019 and 2020, and as a result of the COVID, extreme poverty will increase by 8 million. And there are other reports which are consistent with poverty worsening as a result of the COVID. In terms of inequality, it is manifested in a number of ways. Again, many of my colleagues who went before me have alluded to some of these. But importantly, I think that inequality also showed up in terms of the preparedness of different groups to the shock, the ability of different groups of households to cope with the shocks was actually affected by inequality. And so Mona, Anda David, and LeBron, in a research paper of ASA, point to the fact that pre-existing inequalities shaped readiness and vulnerability outcomes for South Africa. Of course, there are other studies that also point to the COVID exacerbating the existing inequalities. So again, Simone Schultz and others from UNUY that show that the impact of the lockdown as a result of the COVID was felt more by low-income earners in informal work done by, and also by women who had to actually stay at home because, for instance, children were not going to school and women had to stay at home to actually take care of the children. Interestingly, there is also a policy brief which has a very interesting implication of the COVID for inequality. We know that for many African countries today, the school feeding program has come to stay and offers potentially a source of a good meal for many children from low-income households. Now, when schools closed, what it actually meant was that these children then became deprived of the school feeding program and therefore could not essentially get the one good meal a day that they would have if they had been actually going to school. But we know that, again, for children who would have been impacted significantly by this would have been children from relatively poorer households in Africa. And so the point here is that for both poverty and inequality, the research is pointing to the fact that the COVID actually impacted adversely on these. In terms of employment as well, again, of course, I think that because when COVID happened, governments in reaction to the COVID had to first lock down to try and then contain the pandemic. What it also then meant was that livelihoods were significantly or directly affected. In, again, the World Bank's high-frequency survey data that they collected over a number of countries, that for Nigeria shows that for all those who actually lost jobs around May 2020, 85% was because businesses closed. In Chad, for instance, also using similar data, it said that a quarter of the households actually did allude to the fact that their members or no member of their household was actually engaged in any income generating activity around June of 2020. What it meant was that these households, of course, if they had some savings, could then fall back on savings. However, for households that did not have savings, they had to fall on their key assets or sell off their key assets as a coping strategy for the period that the lockdown was in place. Now, in large part and in respect of the employment effects, study done in Ghana looking at the impact of the lockdown on the pandemic shows again that comparing those in employment in the lockdown areas versus those in employment in the no lockdown areas, you find significant differences. And this is based on data across individuals who were all employed in February of 2020. And so this question is asked in respect of April 2020, which essentially tells us that employment was significantly affected because of the policy which had been engendered by the COVID. But again, the effect here is also heterogeneous. So it's not everybody who was affected in the same manner. So those in the informal sector, particularly self-employed, were the most affected, whilst those in the formal wage employment sector were the least affected. Now, the interesting thing in terms of the employment effects is that following the lockdown, you do find, and this is still using the Ghana data, following the lockdown, you do find that the employment levels again pick up, and now you have an equalization of the employment levels in the no lockdown area relative to the lockdown areas. However, comparing the pre-pandemic employment levels to the post-pandemic employment levels, what you do find is that employment was much lower, which is essentially telling us that whilst the policy of the lockdown in itself exacerbated the employment effects, the employment effect as a result of the COVID again lingers, okay? And for how long it will linger will depend essentially on how many more of these waves we are having with respect to the COVID and what policies we actually enact to try and then contain the waves. So what can we make of essentially economic policy in respect of the post-COVID era? Now, in my mind, if there is any one time when economic policy needs to be particularly deliberate and efficient, it is now. It is now because, as we earlier alluded to, this pandemic and the effect of this pandemic is comparable to any adverse economic shock that the global economy has seen over the post-World War era. And so what the pandemic is actually bringing to the fore is that Africa cannot continue to do business as usual. Indeed, that is not an option. And the lag effects of the pandemic remain. The lag effects of the pandemic remain in respect of the fiscal positions. And like I mentioned earlier, because of the debt implications that the fiscal effects of the pandemic has had on countries, it is actually going to play out even after the health side of the pandemic has been curtailed. That will also mean that countries have limited physical space within which to play. Now, we are saying that the poverty implications of the pandemic will remain and linger on for a while. Now, how you deal with the poverty and vulnerabilities which has arisen also out of the pandemic will depend on how much fiscal space countries have. But the debt situation that countries such as Ghana find themselves in mean that dealing with the pandemic will not be too easy. Of course.
Robert,
yes.
You may want to take about 3 minutes just to conclude.
Okay, so we'll finish shortly. Thanks. So we need both growth and employment going forward. Of course, we know that debt has imposed significant constraints on actually dealing with the growth and employment issues from a policy perspective. So economic growth, fiscal policies will remain critical for Africa's recovery. Of course, in my mind, I think investments would or should seek to transform the economy in the most efficient way. But it is essential that we target inclusive growth so that we carry along the poor and the vulnerable. Like I mentioned again, debt means that our constraint for policymaking is real, and we need to actually take into cognizance that constraint. But there is a question of whether there is indeed a policy conundrum. In my mind, I will term it as a conundrum between growth and fiscal space. Some people term it as growth and revenue. Governments need more revenue to deal with the today problem, but more revenue typically in Africa would mean more taxes, which could also mean compromising growth, which indeed is required for dealing with fiscal space. However, if we actually think about the conundrum as a growth and fiscal space rather than growth and revenue, then it means that we are not only reflecting on the revenue side of fiscal space, but we are looking at the other elements of fiscal space, in particular, spending. I believe that we will have to harness both the will as well as capacity in Africa to implement appropriate policies. And appropriate policies that will ensure that growth, poverty, and inequality return to the transformative corridor that it was moving into before the pandemic. But the lingering effects and how long we are able to deal with the health component of this pandemic will be critical in determining how quickly we can actually move the economy back into this critical window for Africa. Thank you very much.
Thank you very much, Professor Say. Just a round of applause for all our three speakers. We have about 5 minutes to take questions and comments before we adjourn for tea. I don't know what the arrangement is regarding taking questions or comments. Are there any questions from the floor? Yes. Yes. Any questions? Any from the audience?
What did we not say?
Okay. It does not look like there are any questions. And that, of course, is a powerful statement about your presentations, which were incredibly lucid. And so if there aren't any questions, I should just want to take this opportunity on behalf of Arua, University of Pretoria, and the University of the Witwatersrand to thank all three of you for your excellent presentations, which have illuminated a number of important issues regarding the economic impact of the pandemic. We are going to take a tea adjournment. And after the tea adjournment, we will resume with the second set of parallel sessions at 1700 hours South African Standard Time. A round of applause for our speakers. Thank you very much, Emma. And thank you, Jane. Much appreciation to you, Robert. Thank you very much.
Thank you.
Thank you. Thank you for the opportunity. Thank you, co-presenters. Thank you.
Great. This brings to an end our session. Over to you, Ernest.
Thank you very much, Sizwe. I think it's also appropriate for us to thank you for your excellent chairing of the session. So, Sizwe, thank you very, very much.
Thank you, my brother.
Okay. So we take a break now for 30 minutes. When we return, we go back to the parallel session rooms. Thank you.